قبل ما نبتدي scientific activity أحب إن احنا نتذكر وننعي أستاذنا وفقيدنا الراحل الأستاذ الدكتور نبيل صبري. الأستاذ الدكتور نبيل صبري له فضل علمي على عدد كبير من تلامذته، وأنا شخصيا بعتبر إن هو أستاذ وأب في نفس الوقت، ومش هتكلم على قيمته العلمية، أنا هذكر بس يعني حاجة عمري ما هنساها له. أنا مريت بتجربة صحية كبيرة وخطيرة من فترة طويلة. أتذكر للدكتور نبيل صبري إن هو الوحيد من كل الزملاء اللي داوم على الاتصال بيا يوميا طول الفترة اللي أنا كنت تعبان فيها، ودي استمرت شهور، واستمر يتصل بيا لغاية ما كان قادر يتصل. يعني هو دكتور نبيل تعب في الفترة الأخيرة جامد وما بقاش قادر يكلم، لغاية قبل ما يتعب كان دايما يسأل عليا، ولا أنساله ده أبدا إن شاء الله. وبدعو الأستاذ الدكتور أحمد شتا إن هو يتفضل يقول كلمة بسيطة في حق الدكتور نبيل صبري. اتفضل يا بيه.
بسم الله الرحمن الرحيم. أولا أشكر الأستاذ الدكتور أحمد مجدي على دعوته الكريمة وتمنيات صادقة بنجاح المؤتمر. وأول ما نبتدي طبعا دي لفتة كريمة إن احنا نعمل اوبيتوري أو تأبين الله يرحمه الدكتور نبيل صبري اللي كان جزء من حياتنا على سنوات طويلة وعشرة عمر. فنبتدي الأول نقف دقيقة حداد آمين. شكرا. الحقيقة الله يرحمه الدكتور نبيل كان رفيق درب ورفيق عمر، لأن تعيننا معيدين تقريبا في وقت قريبين خالص من بعض. وأنا مش هقول طبعا التاريخ اللي كلنا عارفينه، لأن الدكتور نبيل الحقيقة يعني مهما قلنا عنه فمش هنوفيه حقه، لأنه يعني علامة من العلامات علما وأدبا وخلقا وأخ عزيز وله أفضال. زي ما قال الدكتور مجدي كان لا يتوانى عن السؤال عن الجميع. فاللي حبيت يعني أثناء رئاسة القسم كان هو الأمين بتاع المجلس، وكان الناصح الأمين. وأنا يعني دي الناصح الأمين. من الجميل في الحياة إنك تلاقي جنبك واحد قلبه عليك، مخلص، أمين. والدكتور نبيل الله يرحمه كان مثال. يقول لي يا دكتور شتا، لا النقطة دي ممكن تبقى لما نبعت القرار مجلس القسم لمجلس الكلية ممكن نسائل فيها، لا نعملها كذا نسويها كذا. النصح، كون جنبك أخ ناصح أمين، طبعا دي حاجة جميلة في الحياة. الحقيقة طبعا مش هحكي التاريخ إن هو المشاوير اللي عملناها والفترة اللي عملناها. وكان قسم الريون كان منغلق على نفسه، وابتدينا من أول ما حطينا إيدنا في إيد بعض ومع الزملاء كلهم الحقيقة عملنا انفتاح كبير كلكم عارفينه، وأصبحنا رايحين جايين على طول الزقازيق، طنطا، المنصورة، وسوهاج، أسيوط. ودي كانت يعني ثورة كبيرة في الاسم الحقيقة، وخلت قسم العيون بدل ما كان منغلق على نفسه بقى له اسم وله سمعة وله انتشار. والفضل الدكتور نبيل كان كل الرحلات دي كنا بنروحها مع بعض، ودي قربت بينا كتير قوي قوي. وعشان كده الدكتور نبيل يعني في قلبنا كده يعني له معزة. الله يرحمه وكلنا حاسين بيه، وكان قد ايه تعب معانا، وطبعا بالمشاركه مع بعض يعني. كلمه اخيره برضو، الدكتور نبيل الله يرحمه كان يمتاز بالالتزام. التزام. وانا بقول كنا بنروح مع بعض الزقازيق طنطا بالاتوبيسات او بالعربيات، كان يقف على الرصيف قدام باب العماره قبل ميعاده 10 دقايق ربع ساعه قبل ميعاده. الالتزام كان الله يرحمه الدكتور نبيل بيمتاز بالالتزام، ودي طبعا حاجه يعني حاجه حميده، وكلنا مثال لنا جميعا. أنا مش هتكلم بقى عن المستوى الشخصي والعائلي لأنه كان مقرب ليا جدا. من ناحية على مستوى العائلي فكان على طول يسأل على الأسرة ويسأل علينا، يعني يسأل على الأسرة ويسأل على الزملاء كلهم. كلكم عارفين قد إيه هو كان يعني حريص على إن ودي أصالة، يعني هو من أصالته إنه كان دايما يسأل عن الناس وكده يعني، ودي حاجة كويسة أوي. الحقيقة خالص التعازي لنا جميعا، احنا بنعزي نفسنا والله، وبنعزي الدكتورة هبة والدكتور هشام. اللهم اغفر له وارحمه وادخله فسيح جناتك. وشكرا وشكرا.
السلام عليكم ورحمة الله وبركاته. بصراحة بعد الكلام اللي قاله الدكتور شتا أنا مش لاقي إضافات كتير أقولها، بس الدكتور نبيل كان له معزة خاصة عندي. الدكتور نبيل أشرف على رسالة الماجستير بتاعي، وكان التوبيك بتاعها Retinal Sensitivity Thresholds in Juvenile Diabetics in Pre-Retinopathy Stage. فكانت ما شاء الله أفكاره مسابقة العصر، وكان متخيل ومتأكد إن الديابيتس ميليتس بيأثر في الريتنا قبل ظهور الديابيتك ريتينوباثي بمراحل، وخصوصا في الفانكشن وفي السنسيتيفيتي تو لايت. دكتور نبيل كمان أشرف على رسالة الدكتوراه بتاعتي، وكان معاه الدكتور شتا، وكان عنوان الرسالة Optic Disc Configuration Cup in Glaucoma. كل الناس وقتها اتريقوا على المعنى واتريقوا على العنوان. أما سافرت أمريكا وقعدت سنة هناك، وقعدت أدرس in details إيه هو الكونفيجريشن كاب والفرق بينه وبين البالور كاب، حسيت برضو أن الدكتور نبيل مسابقنا بسنين طويلة في فكره عن الجلوكوما، ونشأ عن الفكر ده لأول مرة في مصر يبقى في جمعية للجلوكوما، وكان هو المؤسس الحقيقي للجمعية. طبعا هو ناشد بعض الأطراف في القاهرة، بس هو الأساس اللي نشأ الفكرة بتاعت جمعية الجلوكوما. ده بالنسبة للعلم. الدكتور نبيل أنا اتشرفت بإني أساعده في العيادة لمدة 3 سنين. كل اللي اتعلمته في الأوفثالمولوجي تقريبا من ال3 سنين دول. كل ما بشوف مريض وبتعامل معاه بسترجع الحاجات اللي اتعلمتها منه وبطبقها، وأنا مدين له جزء كبير من النجاح البسيط اللي الواحد يعني لقاه في تعامله مع العيانين، وفي إشرافه على الرسائل، وفي كل الاتشيفمنت سواء على مستوى الكلية أو بره الكلية. من الناحية الاجتماعية أنا كنت طول عمري أعتبر الدكتور نبيل ده أخ كبير أو أب تاني بالنسبة لي. كل الأخلاقيات اللي شفتها منه أخلاقيات سامية، ما شفتش أبدا منه خلق واحد يعني أقدر أعيب عليه، واكتسبت منه حاجات كتير أوي اتعلمتها خلقيا في التعامل مع الناس والتعامل مع المرضى والتعامل عموما. ربنا يرحم الدكتور نبيل ويسكنه فسيح جناته، ولا أزكي على الله أحدا، إنما أنا أعتبره من الصالحين. وشكرا جزيلا.
السلام عليكم. أنا دكتور أحمد المصري. طبعا يعني زي ما انتم شايفين كل جيل بيبقى أصغر من الجيل اللي قبله، واحنا بنتكلم كلام على الدكتور نبيل مش هتكلم غير ان انا تلميذ وهو استاذ. معرفتي بالدكتور نبيل من اول ما خدت عيون سنة 82، هو استاذي اللي رباني، اللي علمني ازاي ابقى نايب كويس، ازاي ان انا ابتدي في الليسته معاه، ومرورا بيه لغايه ما بقيت رئيس قسم. دكتور نبيل من افضله علينا ان هو كان واحنا رؤساء اقسام بينصحنا ويقول لي عملت ايه يا احمد؟ انا بفكر في ستيم سيل لاب تعملوه، بفكر في موليكولار بيولوجي. يعني الراجل يعني سبحان الله الدكتور نبيل فعلا لغايه اخر ايامه كان دايما بينصحنا. 82 اتخرجت، يعني بقى لنا دلوقتي 40 سنه. علاقتي بالدكتور نبيل مرورا بقى من واحد مدرس مساعد وسافرنا وجينا والماجستير والدكتوراه وفي الترقيات كمان، كان من ضمن الناس اللي فيري سبورتيف لينا في كل خطوه. مش هضيف اكتر من اللي الدكتور شتا قاله والدكتور محمد سعد. فعلا يعني احنا فقدنا استاذ واب بمعنى الكلمه. دكتور نبيل فعلا كان يمثل يعني الاب الروحي بالنسبه لنا، وكان فعلا بالنسبه لنا منار علميا وخلقيا. زي ما الدكتور محمد سعد قال لا نزكي على الله احدا، وفعلا نتمنى للدكتور نبيل ان شاء الله انه يكون في فسيح جناته باذن الله، وربنا يرحمه ويجعل قبره روضه من رياض الجنه ويغفر عن سيئاته ويزيد من حسناته. السلام عليكم.
بسم الله الرحمن الرحيم. أنا اسمي هشام الجويني، وبفتخر إن أنا تلميذ الدكتور نبيل صبري على مدار 40 سنة. الحقيقة كل الزملاء والأساتذة الأفاضل قالوا معظم الكلام اللي كنت عايز أقوله، بس الحقيقة الدكتور نبيل أنا بدين ليه بالفضل، كان برضو مشرف بتاعي في الماجستير في الدكتوراه، وخلال فترة طبيب مقيم اتعلمت من الدكتور نبيل كتير جدا. كنت بساعده في العيادة فترة طويلة. دكتور نبيل صبري مع الدكتور شتا كانوا مؤسسين مشروع الجلوكوما، وده كان حاجة لسه جديدة جدا في مصر، وكانت معظم الأجهزة ما كانتش موجودة حتى في البرايفت، كلها كانت موجودة عندنا في مشروع الجلوكوما، وكل الزملاء يعرفوا مشروع الجلوكوما وازاي استفدنا منه. الحقيقة الدكتور نبيل كان يتمتع بخلق يعني أب تاني فعلا. نقول والدنا الدكتور نبيل الله يرحمه طول عمره أستاذ من الزمن الجميل وأخلاق الزمن الجميل والشهامة والرجولة، والناس كل اللي في القسم ما ينسلوش مواقفه مع الجميع كبير وصغير. يوم لستة العمليات كان يوم الأربع ده مشهور، وحدة الدكتور نبيل صبري وحدة ب، يوم الأربع ده لستته من قبل الساعة 8 موجود، ويخش يشتغل العمليات ويفضل قاعد في مكتبه لغايه الساعه 12 الظهر قبل ما يروح العياده مستنينا نقول له اوكي يا دكتور نبيل مفيش مشاكل في الليسته، اتفضل حضرتك. الحقيقه الدكتور نبيل لو الواحد هيقعد يتكلم عليه كتير مش هيوفيه حقه، عمرنا ما هننساه. حتى في مرضه كنا بنروح نزوره في البيت، الحقيقه يرفع السماعه ويسال علينا كلنا واحد واحد، واخبار اولادكم ايه وعاملين ايه واسرتكم ايه. الله يرحمه اتعلمنا منه حاجات كتيرة جدا، مش بس علم الأخلاق اللي مش هتتعوض. اللي برضو مش عايز أطول على حضراتكم، بس زي كل مؤتمر علمي بيقولوا تيك هوم مسج، أنا برضو هاخد تيك هوم مسج من سيرة الدكتور نبيل صبري، واقول لحضراتكم برضو نحترم السينيورتي. كان بيقابل الدكتور شتا يقول له يا دكتور احمد، انا كنت بستغرب هما الاثنين قريبين من بعض، كان الدكتور يقول له الدكتور شتا يا دكتور احمد. الحقيقه احترام السينيورتي، احترام الكبير، العطف على الصغير. اي واحد في زنقه لما بتقف جنبه هيفضل طول عمره شايل لك الجميل ده. فدايما نساعد الصغير وما تقفش في سكه حد. ربنا يرحمه ويحسن خاتمتنا جميعا. شكرا جزيلا.
بسم الله الرحمن الرحيم. احنا سعداء جدا بوجودكم في ال Alexandria Vitreoretinal Society meeting current concepts in diabetic retinopathy bridging the gap between science and patient care. هنبتدي باذن الله scientific program session 1. chairpersons استاذ دكتور سيد جابر، استاذ دكتور يسري حماده.
بسم الله الرحمن الرحيم. أول توك genotypes and phenotypes and trending domain in diabetic retinopathy. دكتور أحمد يونس.
Bismillah. So my presentation today is about diabetic retinopathy, phenotypes and genotypes. Let me start with the question, why do researchers look for other explanations than the classic concepts of the pathogenesis of diabetic retinopathy? Probably it seems that our classic understanding of diabetic retinopathy, its course and progression, is unable to explain some of the statistical findings. For instance, the duration thesis assumes that the longer the patient is exposed to hyperglycemia, the more risk for development of diabetic retinopathy. Some of the research state that after 8 to 10 years, one will develop NPDR. Afterwards, 50% of type 1 diabetics and 20% of type 2 diabetics will develop PDR. The controversy is that what about the remnant 50% type 1 diabetics and 80% type 2 diabetics? Why did not develop diabetic retinopathy or complications of diabetic retinopathy in spite of getting exposed to hyperglycemia for such long period of time? The other question mark is about the VEGF thesis. The VEGF thesis states that overexpression of the vascular endothelial growth factor is a key factor in the development of diabetic retinopathy. Since it's a causative pro-angiogenic and vascular permeability. So the theoretical assumption lead us to believe that with overexpression of vascular endothelial growth factor, there might be concurrent diabetic macular edema and PDR because the factor, the vascular endothelial growth factor, is responsible for both. But practically speaking, it does not happen. When PDR develops, only 15% of patients will develop concurrent diabetic macular edema, and vice versa. Patients with macular edema and increased leakage do not present with neovascularization. Third point is the unequal response to treatment. Many clinical trials actually prove that anti-VEGF therapy is effective treatment for both PDR and center involving diabetic macular edema. Nearly all patients with PDR respond well to complete regression with either 1 or 2 injections. Unfortunately, such robust effect is not seen in diabetic macular edema, and there should be an explanation for that. Only 30 to 40% respond well to anti-VEGF injections, the group of diabetic macular edema. This variability in response to treatment may be attributed to separate or different molecular pathways involved in the development of each phenotype. And here comes the talk about the genotype and phenotype. When we talk about genotyping, we are probably talking about the diabetic retinopathy genomics study, which is a collaborative work between New Mexico University and Joslin Diabetes Center in Harvard. The diabetic retinopathy genomics study uses a clinically supported phenotypic strategy. They study the role of rare variants in diabetic retinopathy progression, protection, and variable response to treatment. The study is interested in genes known to have a role in inflammatory and angiogenesis pathway. When we come to the clinical part, we will be talking about the phenotypes, diabetic retinopathy phenotypes. For the time being, there are two classification systems for diabetic retinopathy phenotypes, the Coimbra system of the Coimbra University in Portugal, and the diabetic retinopathy genomic system, that of Jocelyn Diabetes Center. I'll focus today on Coimbra system because I'm working on it. The Coimbra system work group assume that they have a hypothesis that proliferative diabetic retinopathy is not a stage in diabetic retinopathy, it's a complication. So when we try to classify the diabetic retinopathy, we will classify only non-proliferative because they consider proliferation of new vessels as a complication, not a disease stage, such as tractional retinal detachment and vitreous hemorrhage. They are not stages, they are complications. So they consider PDR as a complication, not a stage. On that basis, they classify the phenotypes, the morphological phenotypes, into three phenotypes, A, B, and C. And I would want to make a note that I don't want to mix up the staging, the ETDRS staging, and the phenotyping. Staging is based upon severity and progress of the disease, but the phenotyping is based upon the morphological characteristics and the speed of progress of the disease, not the severity. So Coimbra phenotype non-proliferative diabetic retinopathy into phenotype A, in which the patient do not develop any diabetic retinopathy in spite of getting exposed to hyperglycemia for more than 20 years. Phenotype B, which is the exudative part, the patient develops macular edema very fast, and he could keep developing macular edema for a very long period of time without showing any ischemic manifestations. Phenotype C is the ischemic, and which is the most rapid and the most aggressive form. I refer to the Jocelyn classification, but I will not talk about it today. The group A is like the group 1 is like group A in no diabetic retinopathy for 20 years. Group 2, they consider proliferative diabetic retinopathy as a stage. That's like the ETDRS classification, and group 3, the DME. So let's define phenotyping. Phenotyping refers to distinguishing different morphological forms of the disease according to the progress pattern and speed. I tried to find a translation, so it's like fasila in Arabic. It's fasila, no, it's not a class. So it's the phenotype, the phenotypes of the disease are it's to distinguish different morphological forms of the disease according to progress pattern and speed. According to the theory, NPDR phenotypes helps in prognosis expectation and treatment strategy planning. The two variables that help us phenotype diabetic retinopathy are the central foveal thickness and the microaneurysm turnover. Microaneurysm turnover is defined by the Coimbra group as the sum of microaneurysm formation and disappearance rate determined in a given period of time. During that period of time, the fluctuation in central foveal thickness is measured. This process could be done in two ways. One, manually by manual counting of the microaneurysm, or by using the RIT marker DR. The RIT marker DR is a commercially available software, and I have no financial interest. This software works by dealing with microaneurysms as a single entity in specific location. So it compares the pictures of the same patient on different visits to see the newly formed microaneurysms, disappeared microaneurysms, and withstanding microaneurysms along the different visits. Here is a definition, the mathematical definition. The criteria to phenotype A, the microaneurysm turnover calculation is less than 6, and central retinal thickness is less than 260 for females and 275 for males. This phenotype is characterized by the slowest progression, best prognosis, and it usually does not require treatment over long periods of time. Phenotype B the microaneurysm turnover is more than 6, and this is the characteristic part of phenotype B, the microaneurysm turnover. The characteristic part of phenotype B is the central subfield thickness should usually be more than 260 for females and 275 for males. Phenotype B is known to be the wet form of NPDR. It shows the fastest rate of developing and increasing cystoid macular edema. However, the ischemic component is not presenting even over long periods of time. Phenotype C, the characteristic part of phenotype C is the very rapid microaneurysm turnover, which is usually over 6. It might present with or without cystoid macular edema. This phenotype is known to be the most aggressive form. It progresses rapidly to PDR and it carries the worst prognosis. Okay, this is a clinical study. I don't want to mention it. So to sum up, diabetic retinopathy is a disease with heterogeneous phenotypes with multifactorial influence. Considering classical variants such as duration, metabolic control, HbA1c, insulin dependence, hypertension. By the way, this is the presentation of Mohammed Masri. What I want to say that these variants could explain only part of the story, but not the whole story. There is almost 50% of the story not told by using such only these factors. Morphological observation of the disease helped in categorizing the so-called phenotypes. Phenotypes have been proven of ability to explain pathways of the disease in spite of similar environmental factors and treatment. The phenotype theory is based on a hidden part, which is the genomic structure. That's the scope of diabetic retinopathy genomic study. While clinical evidence indicate the genetic role in diabetic retinopathy, their precise role is still elusive. Genetic studies reached now a very advanced level that it can predict the height of a person, a disease like Crohn's disease before it happens, but still it did not reach that point of accuracy in diabetic retinopathy. The ultimate target beyond these studies is accurate prediction of disease and its response to treatment. Thank you.
دكتور حمام متولي هيقدم لنا classification of diabetic retinopathy.
Assalamu alaikum. I'm very happy to be here with you today. Today we are going to talk about the classification of diabetic retinopathy. Okay. At first, I want to explain the diabetic retinopathy classification in a chronological fashion. I'll get it in a history of the classification, and we'll go on up till now. First, in 1986, it was first in Airline House, Virginia. They stated a meeting to discuss the management of diabetic retinopathy. At that time, the state of knowledge of diabetic retinopathy was reviewed by experts, and they came out with the first classification for diabetic retinopathy. After that, diabetic retinopathy study and ETDRS, early treatment of diabetic retinopathy, they modified this classification to come out with the diabetic retinopathy severity scale. That scale was very difficult, and it has many levels. From level 10, it's no retinopathy, till advanced proliferative retinopathy in level 95. This was good for the research work, but not for clinical use. And it was based on a stereoscopic color fundus photos. At that time, fluorescein angiography didn't give any other improvement for this classification. The recent classification we are using today, it was a modification of these classifications, and it's called the International Clinical Disease Severity Scale of Diabetic Retinopathy. It was based upon the findings of the Wisconsin epidemiological study of diabetic retinopathy and the ETDRS. This classification is simple to use and easy to remember, and based on clinical evidence. It classified the diabetic retinopathy into 5 stages. First, no retinopathy. Second, mild, moderate, severe, non-PDR, and peripheral diabetic retinopathy. This is the historical chronological fashion of classifying diabetic retinopathy. As you can see, the International Clinical Diabetic Retinopathy Scale was 2003. Early treatment diabetic retinopathy, it was from 79 till 90, and it came last at 91 with the last classification. The diabetic control and complication trial for type 1 diabetes mellitus, UK prospective diabetic study for type 2 diabetes mellitus, diabetic retinopathy study 71 to 75, and the diabetic vitrectomy retinopathy study from 79 to 90. As you can see, the first classification into 5 stages. Second classification, they make the severe non-PDR into severe and very severe. Also, the PDR into early, high risk, and severe PDR. The same for diabetic retinopathy study and the early treatment diabetic retinopathy study, diabetic vitrectomy retinopathy study. Okay, the International Clinical Disease Severity Scale. The first is no retinopathy. Second, there is only microaneurysms. Third, there is microaneurysms, intraretinal hemorrhages, and venous bleedings, according to standard photos that came in the paper, the original paper itself. The fourth stage is severe non-PDR, and at this stage, the key level to identify, because at this stage, 50% there is a chance to develop high-risk PDR in about 6 months if the laser treatment is not done. It is diagnosed according to the 4-2-1 rule. They use the standard photographs in the original paper. If there is hemorrhage in 4 quadrants of the retina, or if there is 2 quadrants having venous bleeding, or 1 quadrant with intraretinal microvascular abnormalities. These are the standard photos that came in the original paper. These are the intraretinal hemorrhages if they are present in 4 quadrants. This is the venous bleeding if it's present in 2 quadrants, and this is the ERMA or the intraretinal microvascular abnormalities if present in only 1 quadrant. It's classified as severe non-PDR. The 5th stage is the peripheral diabetic retinopathy, neovascularization of the disc of the retina, the iris, the angle, vitreous hemorrhage, or traction detachment. In this classification, they classified macular edema into mild, moderate, and severe. If the hard axes are away from the fovea, it's mild. If it's near the fovea with no thickening, it's moderate. If it is in the threatening the fovea with thickening, it is severe diabetic macular edema. Very severe, it's only 2 criteria of the severe if are present in the same time. PDR, neovascularization, high risk PDR if the neovascularization is in the disc, more than 1/3 of the disc, or if neovascularization in the disc and there is vitreous hemorrhage, or if there is no neovascularization elsewhere with vitreous hemorrhage and preretinal hemorrhage. Severe PDR if I cannot see the posterior fundus, or if there is traction detachment at the center of the macula. Historically, also, diabetic macular edema was classified, as I told you, by the ETDRS, using the clinical pictures, fundus photographs. It was a classification that's time-consuming, and it was not reproducible. They also introduced the DERM, clinically significant macular edema, that was defined as a thickening of the retina 500 microns of the center of the macula, hard axis within 500 microns with retinal thickening, or a zone of retinal thickening 1 disc area or larger. This was the base for the treatment of macular photocoagulation for clinical significant macular edema, and this was in 1991, 30 years from now. They also used the fluorescein angiography in classifying diabetic macular edema as a focal if there is more than 2/3 of the leakage come from microaneurysm. If there is 1 to 2/3 coming from microaneurysm, it's intermediate. If there is less than 1/3 of the leakage is coming from microaneurysm, it's diffuse. At 2004, OCT have been introduced to classify diabetic macular edema, and there were many attempts to use it because it is accurate, it is give a good picture of the edema. Also, but it was expensive and needs trained personnel to operate. There was a first attempt by Panuzzo et al. In 2004. but they found that was disagreement about the OCT findings and the clinical significant macular edema definition by clinical examination. Panuzzo at 2004 classified macular edema into these stages, either edema, thickening, and traction. E1 is simple thickening of the retina, and this was the OCT pictures that came in the original paper in 2004. It's very bad quality than we know now, as you can see. E2-1, there is only 2 or 4 cysts with minimal thickening. E2B, large cysts, as you can see. This new is E3, neurosensory detachment. Large cysts, but less than 400 microns. E2C, large cysts with more than 200 microns. E3 is neurosensory detachment. And the traction, either T0 is no traction, T1 just epimacular membrane with no tangential traction, T2 is tangential traction, and T3 is gull-wing appearance. This was the original pictures from the original paper 2004. Now there is an OCT-based grading diabetic maculopathy proposed by an international expert panel at the European School of Advanced Studies in Ophthalmology, and this was published in January 2020, also by Panuzzo et al., the same Panuzzo from 2004. This study was just a literature review from what's published before 2019, and they are reviewing all the OCT images for a large number of patients, and they came with 7 tomographic quantitative and qualitative features that are taken into account to score according to the grading protocol termed thickening, cyst, edema, and disorganization of the interretinal layers. Well, H is for hard exits or hyperreflective foci, fluid in the retina, and the vitreomacular interface. There were 4 different stages that are based on these 4 variables, T, C, and E, and D, with stages that reflect the progressive severity of the disease. This classification is aimed to become simple, direct, and objective tool to classify diabetic maculopathy. It can be used by non-internet experts to diagnose and therapeutic and prognostic purposes of diabetic macular edema. This is the original table from the original study. As you can see, thickening 2 stages, cysts in the retina, 1, 2, 3, ellipsoid zone and epiretinal membrane is E, drill or disorganization of the retina, inner retinal layers, retinal layers, hyperreflective foci, subretinal fluid, and vitreoretinal interface. Either is it incomplete vitreoretinal, incomplete PVD, complete PVD, vitreomacular traction, or epiretinal membranes. They stated that there are 4 levels of maculopathy. First, the early maculopathy, as you can see. Then the advanced maculopathy. Then the severe maculopathy. Then atrophic maculopathy. And lastly, they classified the interretinal interface into hyperreflective foci, subretinal fluid, and vitreoretinal relationship by these pictures from the original study. Thank you.
دلوقتي بيبر هيقولها الدكتور محمد أشرف المصري Ultra Wide Field Imaging of Diabetic Retinopathy Past, Present and Future. الديمو. دكتور احمد سامعني؟ محمد معلش. دكتور مصري. ايوه
الو.
ايوه سامعينك يا دكتور
طيب
محمد.
سامعني؟
اتفضل.
طيب تمام. انا سامع حضرتك. الو. ايوه سامع حضرتك.
اتفضل يا حبيبي اتفضل.
Okay, I would like to thank the AVRS for giving me the opportunity to present here today. So let's start off with some definitions. So what is ultra-wide field imaging? Now, based on an expert panel, it is defined as
ايوه دكتور محمد اتفضل.
Okay, so let's start off with some definitions first. What is ultra-wide field imaging? So based on an expert panel, it is defined as imaging of the retinal anatomic features anterior to the vortex veins in all four quadrants. Now, based on the expert panel, the posterior pole represents around 50 degrees and extends to the area just beyond the disc and the arcades. The mid-periphery has a field of view of around 60 to 100 degrees and extends to the vortex vein ampullus, while the far periphery is a field of view 110 to 220 degrees and is anterior to the vortex veins. The Optos ultra-wide field camera is able to image approximately 82% of the total retinal area, or a field of view of 200 degrees.
دكتور محمد البرزنتيشن بتاعك
Will share screen disabled? طب كده شايفين الدنيا كويس؟
تمام كده.
Okay. Okay. All right, so this is just a recap of what I just said. So this is an ICG ultra-wide field image, and based on the expert panel, imaging of the area beyond the areas of the vortex veins is what is defined as ultra-wide field imaging. And based on that definition, the posterior pole is the central 50 degrees. The mid-periphery is around 60 to 100 degrees. And the far periphery is beyond the vortex veins, which is around 110 to 220 degrees. Now, there are a lot of cameras out there in the market. Probably the one that images the most is the Optos. It can acquire around 82% of the total retinal area, which is around 200 degrees field of view. Now, the other cameras don't reach quite as far out to the far periphery. They can image the mid-periphery, but they have some difficulty imaging the far periphery. Now, the gold standard so just to confirm, are you able to see my slides?
Yes, we can see.
Yes, you can see. Okay, great. All right, so the gold standard for diabetic retinopathy grading is the ETDRS 7 standard fields, as Dr. Mitwalli just highlighted. Now, ultra-wide field imaging is changing the manner by which we can evaluate diabetic retinopathy by providing high-resolution images of a large area of the retina in a single image. Now, using the traditional ETDRS photos, only around 30% of the total retinal area can be visualized. Using ultra-wide field imaging, 200 degrees, or approximately 82% of the total retinal area can be visualized in a single image. Now the question is, does area visualized actually affect the accuracy of DR grading? Now the traditional 2-field and 5-field imaging captures the posterior pole and parts of the mid-periphery. The greater the area image, the greater the sensitivity in detecting diabetic retinopathy in comparison to the gold standard. So when the Optos ultra-wide field came out, one of the biggest questions was how effective it was and how accurate it was. So to judge whether the ultra-wide field cameras, and specifically the Optos, can be used for DR grading, in 2019, the DRCR published the first results of their prospective study, Protocol AA, evaluating its use in diabetic retinopathy. And just of note that that study used an earlier model of the Optos, the TX, and not the currently available California. So the primary objective of the study was to compare similar areas acquired by the two imaging modalities to see if they were comparable. And the study determined that the quality of the Optos ultra-wide field in imaging the 7 standard fields was equivalent to that of the Topcon steered 7 fields. The second objective of the study was to see if additional diabetic retinopathy lesions could be identified in the area beyond the 7 standard fields. So let's first discuss some definitions. For each ETDRS field, there is a respective peripheral field. As an example, in this image, highlighted by the yellow arrow is ETDRS field 3. And now highlighted in red is the peripheral or extended field 3. Now, based on the density of individual DR lesions in each ETDRS field and their respective extended fields, several patterns of diabetic retinopathy have been observed. Now, the first pattern is called predominantly central. This involves having more DR lesions in the ETDRS field than its respective peripheral field. And here's an example showing temporal field 3, showing significantly greater lesions in the ETDRS field than the peripheral field. The second pattern is uniformly distributed. Here, the DR lesions are distributed evenly between the ETDRS field and its respective peripheral field. And here's an example of an FA of field 3 showing the uniform distribution. The final pattern is predominantly peripheral, or PPL for short. In eyes with PPL, there are significantly more lesions in the peripheral extended fields compared to the central field. And here's an FA highlighting field 3 in an eye with PPL. Now, in the DRCR study, when looking at all diabetic retinopathy lesions, approximately 51% were predominantly central, 34% uniformly distributed, and 15% predominantly peripheral. It's also interesting to note that 54% of NDEs were predominantly peripheral. In eyes with predominantly peripheral lesions, grading the periphery resulted in a greater DR severity in 27% of eyes, meaning that these eyes might have been graded as mild on ETDRS, but when examining the periphery, they were judged to be moderate or severe. Now, why is PPL so important? Well, earlier prospective data from the Joslin Diabetes Center had shown that PPL is associated with a 4.2 higher risk of PDR development, regardless the level of DR severity. This means that PPL was an independent predictor for worsening. These results are currently being evaluated, and Protocol AA is expected to release further papers this summer highlighting the progression longitudinal data. One of the reasons why PPL was suggested to be associated with increased progression and development of PDR was that they were associated with significant peripheral non-perfusion, indicating that these eyes were generally more diseased than others. So is this the new standard of care? Well, we're still waiting for the DRCR 4-year longitudinal data, but the DRCR has already moved to make ultra-wide field the gold standard in all its upcoming clinical trials, including the current DRCR Protocol AF, for which I'm currently an investigator. So how about the role of ultra-wide field FA in DR? Well, ultra-wide field FA can allow us to detect more lesions and can allow us to visualize and quantify non-perfusion. With regards to detecting more lesions, just comparing between the ultra-wide field color and the ultra-wide field FA, you can see that the FA detects significantly greater lesions. In a joint PhD thesis between Joslin and Alexandria University, it was demonstrated that ultra-wide field can detect up to 3.5 times more MAs than color images. This may be important in the future as we move towards quantitative ultra-wide field imaging, where you can have eyes in the same level of retinopathy but with different lesion counts. Earlier results published by our group at Joslin and Arvo had shown that greater counts in the far periphery can help predict progression to PDR. Now, what about detecting NVEs? As you can remember, we already said that 50% of NVEs were found in the far periphery beyond the 7 fields. So let me show you a few examples. In this eye, when evaluating the ETDRS fields, the eye could be graded as having NPDR. However, the ETDRS, beyond the ETDRS field, extensive NVEs can be seen. This is another example. This is a similar example with NPDR graded in the 7 fields, but with NVEs in the far periphery. However, it's important to note that the sensitivity of ultra-wide field color images is similar to that of ultra-wide field FA in detecting NVEs, provided a trained certified grader is assessing the images. These results were published by Siva Prasad and her group, and they mirror similar results published by our group at Arvo. How about peripheral non-perfusion? Now, ultra-wide field FA can allow us to detect non-perfusion in the posterior pole, mid-periphery, and far periphery. It is also particularly useful in the far periphery, which is poorly imaged by classic FA. A novel area that is being explored is non-perfusion quantification. Now, previously, a manual grader would need to quantify the amount of non-perfusion. However, current AI technology can detect and quantify non-perfusion automatically. However, some questions still remain, and we're waiting for the results of AA, which will be released sometime this year, to determine whether ultra-wide field non-perfusion quantification should be part of standard of care. Now, ultra-wide field imaging has also brought about a paradigm shift in DR screening. Now, a major advantage of these cameras is the ability to image over 80% of the retina through an undilated pupil in less than a second without having the patient look in different directions. Now, this was a very large study that was done comparing traditional non-mydriatic multi-field imaging to ultra-wide field imaging in a large number of active DR screening programs in the US. The ungradable rate for traditional 3-field non-mydriatic multi-field photos was 27%, compared to only 3% for ultra-wide field non-mydriatic imaging, and this represents a 10-fold decrease. Similarly, ultra-wide field imaging detected almost double the number of eyes with any diabetic retinopathy and referable diabetic retinopathy, meaning that we can detect more eyes that are diseased that need referral. Now, another unexpected benefit was the number of non-diabetic findings detected on ultra-wide field imaging as a part of screening. Almost 22% of eyes had non-diabetic findings, and in addition to the central retinal findings such as drusen, vein occlusions, glaucoma, etc., ultra-wide field imaging detected a significant number of tears, lattice, and nevi. Now, in summary, ultra-wide field color imaging detects peripheral diabetic retinopathy lesions, and this results in an increased DR severity grading in over 27% of eyes. Ultra-wide field imaging also detects a subset of eyes with PPL, which is associated with an increased risk of DR progression and PDR development. Ultra-wide field FA detects more peripheral NVEs compared to standard FA. However, the sensitivity of ultra-wide field FA is similar to ultra-wide field color imaging, provided a trained grader assesses the images. Ultra-wide field FA detects peripheral non-perfusion, and it is unclear if non-perfusion quantification adds additional prognostic value pending DRCR AA results this year. In DR screening programs, ultra-wide field imaging can provide non-mydriatic fast imaging of the entire retina with a lower ungradable rate, ability to detect more DR lesions, and peripheral non-DR lesions. And so in conclusion, ultra-wide field color imaging is fast becoming the standard of care in grading and diagnosis of diabetic retinopathy. Ultra-wide field FA facilitates detection of NVE and non-perfusion. However, its clinical utility compared to color imaging is still being evaluated. And ultra-wide field color imaging is paradigm changing in the field of diabetic retinopathy screening programs. Finally, I would like to note that ultra-wide field imaging has finally arrived in Egypt, and here are a few examples of some of the images of patients that were imaged using the ultra-wide field cameras in Egypt. Finally, I would like to thank all my mentors, colleagues back here at Harvard and at the Joslin Diabetes Center. And I would like to thank the AVRS for giving me the opportunity to speak here today. Thank you.
شكرا دكتور محمد على التوك الجميل ده وبالتوفيق.
بسم الله الرحمن الرحيم. الدكتورة أميرة بس تعتذر، هي تعبت امبارح فبعتت لنا البرزنتيشن بتاعتها ريكوردد، نسمع.
بسم الله الرحمن الرحيم. النهارده هنتكلم باختصار عن دور ال OCT in management of DME patients. زي ما احنا عارفين ان ال OCT دلوقتي هو the most valuable tool in diagnosis and treatment of DME patients، لانه طبعا non-invasive tool, less likely to be affected by media opacities, less time consuming, provides more accurate and more reproducible quantitative estimation of macular edema and its change with the treatment، وكمان بيدينا detailed examination of the different retinal layers. أهم معلومة بيديها لنا ال OCT هو ال central subfield thickness defined as macular thickness involving central 1 mm area on the ETDRS grid circle. ال central subfoveal thickness هو ال highly reproducible standard for application and monitoring of anti-VEGF treatment، لكنه في نفس الوقت هو مجرد one factor among others اللي ممكن يأثروا على ال final outcome of the patient، سواء functional كvisual acuity أو anatomical، يعني شكل الإديمة في ال OCT. ومن هنا جت فكرة البايوماركرز. بايوماركرز معناها ببساطة ان في changes at different layers of the macula أو of the retina. ال changes دي ممكن تدينا فكرة عن what will happen أو تبقى ليها prognostic value regarding ال final visual outcome بتاع العيان أو ال response بتاعه للتريتمنت. من ضمن البايوماركرز او الفاكتورز دي هو الباترن اوف إديما. generally speaking عندنا 3 انواع اساسيه او 3 patterns اساسيين من ال center involving diabetic macular edema، هي spongy form macular edema والcystoid macular edema والSRF او subretinal fluid pattern. السبونجي فورم باترن او السبونجي فورم ثيكنينج اللي بيبقى واخد الفوفيال زون ده غالبا بيبقى على الليفل بتاع الاوتر بليكسي فورم لاير. السب ريتنال فلويد طبعا بيأكيموليت ما بين الار بي اي والاوتر ريتنال لايرز. اما السيستويد سبيسز فغالبا بتبقى فورمد على الليفل بتاع الانر نيوكلير والاوتر بليكسي فورم لايرز. هل شكل الإديمة ليه دور؟ ايوه. البيشنتس اللي بيبقى عندهم سبونجي فورم إديمة غالبا نظرهم بيبقى افضل مقارنة بالبيشنتس اللي عندهم سيستويد ماكلر إديمة او عندهم سبريتينال فلويد اور بوث، especially لو كان البيشنتس دول عندهم سيستويد ماكلر إديمة chronic with severing of molar fibers، لان loss of molar fibers اللي ما بين السيستويد spaces ده معناها ان في some sort of neuronal degeneration اللي بيبقى له effect بعد كده على transmission of signals ما بين الفوتوريسبتورز والGCL. presence of subretinal fluid هل ليه effect او ليه prognostic value لنظر البيشنت؟ it's debatable، لكن الحاجة الأساسية إن البيشنتس اللي بيجوا عندهم subretinal fluid at the time of presentation غالبا بيبقى عندهم good response للتريتمنت with anti-VEGFs، والvisual acuity بتبقى depending على other factors تانية زي integration of outer retinal layers أو presence of vitreomacular interface abnormalities. بذكر الفيتروماكلر انترفيس ابنورماليتيز طبعا دي موجوده في الاو سي تي سكانز في حوالي 60% من البيشنتس اللي عندهم دي ام اي، وبتبقى على هيئه epiretinal membranes او vitreomacular adhesions او vitreomacular tractions. البريزنس اوف vitreomacular tractions وخاصه لو كانت thick وبرود بيبقى اكتر في اتجاه السيرجري. لكن لو الفيتروماكلر ادهيجنز دي كانت فين او مفيش معاها فوكال تراكشنز، فغالبا ممكن البيشنت يكمل في اتجاه الميديكال تريتمنت او العلاج بالانتي فيجابس. وبيفضل في وجود اي فيتروماكلر انترفيس ابنورماليتي ان يبقى في دايما كونسلتيشن مع الفيتروريتنال سيرجن علشان نختار البيست تشويس كتريتمنت فور this particular patients. الحاجة اللي بعد كده هي الدرول او الديسورجانيزيشن اوف retinal outer retinal layers. الاوتر retinal layers اللي هي الريتنال layers اللي ما بين الار بي اي والاكسترنال limiting membranes، وبيتقسموا الى photoreceptor outer segments ISOS junctions وphotoreceptor inner segments والاكسترنال limiting membranes. الايفالويشن اوف outer retinal layers بيبقى من حتتين. الحته الاولانيه thickness measurements، وده بيبقى يا اما manual يا اما automated على حسب الماشين. والحاجة التانية quantitative من حتة الستراكشرال انتجريتي بتاعة الاوتر ريتنال لايرز. من ناحية الثيكنس الفوتوريسبتور اوتر سيجمنت لينس الافريج بتاعها بيبقى في حدود 40 مايكرون في الفوفيال زون in healthy individuals. ومن زمان الفوتوريسبتور اوتر سيجمنت لينس لقوه في ستاديز كتير ان هو correlates مع الفيجوال acuity of patients with DME. ليه؟ لأن anatomically الفوتوريسبتور outer segments هو المكان اللي فيه الابسنت فيلد ديسكس اللي بيحصل فيها عملية اللايت absorption and transduction، وبالتالي ليه دور في الفوتوكيميكال process of vision. في ال DME patients بيحصل shortening للفوتوريسبتور outer segments، وده بسبب الcombined effect of التيشو ischemia، يعني بيبقى فيه lipid and fluid exudation، وكمان بيبقى فيه accumulation of toxic metabolic waste products و inflammatory mediators على الفوتوريسبتورز. زي ما قلت غير التكنس كمان فيه الستراكشرال integrity، والستراكشرال integrity بتاعة الاوتر ريتنال لايرز بتبقى distorted في البيشنتس with severe diabetic retinopathy status، وكمان في البيشنتس اللي عندهم chronic diabetic macular edema. والpresence of drool او distortion of retinal outer layers correlates well with visual acuity. Is it reversible؟ ايوه، بيقال ان الانتي فيجاف تريتمنتس بيبقى ليها ايفكت ان هي بتعمل improvement للنيورونال ديسفانكشن. كمان مع الريزولوشن اوف ايديما بيحصل some sort of repair of structural deformity of الاوتر retinal layers، فيحصل restoration للإليبسويد زون. mostly الاكسترنال limiting membrane بيبقى more resistant to be repaired، عشان كده لما بيحصل فيه damage غالبا بيبقى persistent. هنا عندنا examples ل variable degrees of drool. الصورة اللي فوق على الشمال يا دوب في altered reflectivity للإليبسويد زون، جنبها في شوية mild compression للفوتوريسبتورز. الصورة اللي تحت على الشمال في عندنا loss of الإليبسويد زون و distortion في الإكسترنال limiting membrane. والصورة الأخيرة اللي في اليمين في عندنا complete loss للفوتوريسبتورز والإكسترنال limiting membrane at the foveal zone. ليه الايفكت بتاع الاكسترنال ليميتنج ممبرين على الفيجن وعلى الريسبونس تو تريتمنت اكتر من الفوتوريسبتورز؟ لان حدوث ديسربشن على مستوى الاكسترنال ليميتنج ممبرين ممكن يساعد اكتر ان يبقى في بلاد كونستيتيوينتس موجوده اكتر في السب ريتنال سبيس، فيعمل further damage للفوتوريسبتورز. كمان loss of the external limiting membrane بيؤدي الى loss of its barrier function، وبالتالي يحصل اكتر dysregulation للفلويد dynamics with subsequent intra and subretinal fluid accumulation. الحاجة الأخيرة والمهمة هي الساين اللي كلنا بنسمع عنها اللي هي الدريل أو الديستورشن of retinal inner layers، وده التعريف بتاعها إن يبقى في inability to follow the boundaries of the GCL IBL complex INL and or OPL over the central 1 millimeter area of the ETDRS grid regardless of presence or absence of macular edema. زي كده الصورة اللي احنا شايفينها، الصورة اللي على الشمال في عندنا ال discontinuation of اللايرز او الدريل في حين ان البيشنت ما عندوش ماكيولار اديما، والصوره اللي على اليمين في ستويد ماكيولار اديما وكل حاجه لكن كل اللايرز ار انتاكت. presence of drill معناه ان في anatomical interruption للفيجوال باثواي ما بين الفوتوريسبتورز والجي سي ال، وده بيحصل بسبب ان في بيحصل كمان دامج للسبورتنج سيلز زي الهوريزونتال والاماكراين والبايبولر سيلز. لو عملنا فلوريسين او خدنا فاندس فوتوغرافي للبيشنتس اللي عندهم دريل غالبا هنلاقي فيه areas of macular ischemia وانلارجمنت في الفاز. Centrally located drill correlates well with visual acuity according to studies by Sun et al. هم أول ناس وصفوا الدريل ساين ودرسوها وقالوا ان وجود الدريل at baseline او at the time of presentation and its change correlates مع الفيجوال acuity outcome in patients treated with anti-DGF. هل هي reversible؟ قالوا الريزولوشن باترن بتاعها variable، ممكن يبقى فيه early resolution او late resolution، ممكن يبقى فيه inconsistent resolution يعني يحصل drill ويحصل له improvement ويرجع ويروح، وممكن يبقى persistent ودوت the worst type. من الاستاديز بتاعتهم لقوا on average ان في السنترال 1 ملم foveal zone لكل drill increase 300 مايكرون من التايم اوف برزنتيشن لمدة 4 شهور بيحصل ريدكشن في الفيجوال اكيويتي بتقريبا 1 لاين. كمان لقوا الناس اللي بيبقى عندهم البرزيستنت او الانكونسيستنت باترن دايما بيبقى عندهم الفيجوال اكيويتي جينز بتبقى اقل من البيشنتس اللي عندهم patterns of early او late resolution patterns. To summarize, the OCT is a crucial tool for diagnosis and management of diabetic macular edema. The thickness is one factor among others to look for on OCT scan. Patients with chronic cystoid macular edema with large size cystic spaces and the severe demolar fibers are usually having underlying drool, presenting with poor visual acuity, and usually their response to anti-VEGF treatments is suboptimal. Similarly, patients اللي بيبقى عندهم drill with great extent أو عندهم external limiting membrane distortion بيبقى عندهم برضو poor visual acuity و suboptimum response to anti-VEGF treatment. على العكس patients اللي بيبقوا presenting without drill with intact outer retinal layers especially external limiting membrane وعندهم center involving diabetic macular edema غالبا عندهم better chance for edema to resolve with subsequent improvement of visual acuity. وأخيرا presence of epimacular membranes has no impact on visual acuity or response to treatment unless associated with vitromacular traction or other structural abnormalities. شكرا جزيلا.
بنشكر دكتورة أميرة وربنا يشفيها إن شاء الله.
The next speaker is محمد كمال. قدمنا virtual clinics, artificial intelligence and fluorescein angiography in diabetic retinopathy and diabetic.
هو ليه مش عامل بريزنت ريفيو؟ ليه مش بريزنت ريفيو عندي؟
طيب محمد منصف خربوش OCT angio, could it make difference in diagnosis?
انت فاهم دلوقتي اللي حصل صح؟ كده عاملين ده هنا مش بريزنتر معلش ثانية واحدة. اوكي اوكي كده makes sense. Good evening, my dear professor and colleagues. Today I'm going to talk about the OCT and geography to answer the question, could it make a difference in diagnosis? There are growing numbers of imaging modalities that can be used in the screening, evaluation, and diagnosis treatment of diabetic retinopathy. The standard, of course, is a dye-based fluorescein angiography. OCTA emerged as a rapid, non-invasive modality for assessing microvascular changes to overcome the drawbacks of fluorescein angiography. The drawbacks of fluorescein angiography, it's an invasive technique, requires intravenous administration of a dye. This dye poses risk of mild allergic reaction to anaphylaxis. It's relatively expensive, time-consuming, not ideal for screening and repeated application, cannot separately visualize the intraretinal structures of the major capillary networks. The deeper retinal capillaries are not visualized, probably because of light scattering in the retina, has limited ability to visualize the choroidal vasculature, and leakage in the fluorescein angiography may mask the microvascular alterations. The principle of OCT, as we all know, is a repeated OCT-B scans at the same location to detect the change in the movement of red blood cells through the blood vessels to give a 3D or a depth visualized architecture of each capillary layer. So the advantage of the OCTA, it's a non-invasive technique, detailed assessment of changes in the retinal microvasculature without dye injection, can be obtained more frequently, it's more rapid, it has 3-dimensional and depth resolved, so each individual capillary plexus can be assessed. The morphological changes in diabetic retinopathy using the OCT angiography. Let's start with the microaneurysms. Microaneurysms, as we all know, are the first detectable sign in diabetic retinopathy. And in fluorescein angiography, they are detected as a homogeneous hyperfluorescence punctate spots. Multiple studies showed that the microaneurysms were located mainly at the deep plexus using the OCT angiography. Some studies found that the OCT angiography could detect microaneurysms that are not detectable in fluorescein angiography. While most of the studies, the detection rate was lower, about 85% sensitivity. This was because it was flow dependent. The OCT angiography has a threshold to detect the flow. So most likely the relative sensitivity of OCT angiography is because certain subtypes of the microaneurysm has a slow flow inside of them. Also, the OCT angiography can delineate various subtypes of the aneurysm, as you can see in this picture. We have the focal bulging, we have the saccular with the fusiform, the mixed saccular fusiform, and the pedunculated and the irregular. This is a very nice illustration of an OCT angiography of a patient, and the same patient has a fluorescein angiography, the early and late phase. We can see here the blue circles, the aneurysms. هو الليزر مش باين؟ طيب. The blue circles delineating the non-leaky aneurysms, while the white circles delineating the leaky aneurysms. And in the fluorescein angiography, you will see a dotted circles. They are not detected in the fluorescein angiography. This is probably because they are slow flow microaneurysms. Computer علق. Computer علق.
هي فين بتاعت
هي خربوش دي.
هو هيفتح. هي دي صح؟ هي دي؟
لا. هي دي. مظبوط مظبوط. تمام تمام. طيب. Regarding the ERMAs, OCT with the conventional OCT-B scan has the advantage of displaying both the en-face and the cross-sectional views to assess differentiated ERMAs from the new vessels. In OCTA, ERMAs appears abnormal branching dilated retinal vessels that do not protrude into the vitreous above the ILM. This is a fluorescein angiography. Of course, sometimes we get confused. Is this a leaky vessel or not? here it's very well delineated that it's below the ILM. Regarding the new vessels, on fluorescein angiography, of course, the new vessels are detected on identifying the vessels with the excessive leakage on later phase. But this excessive leakage can obscure the vascular details. However, in the OCT angiography, there is no dye. It depends on RBC movement, so the dye has no impact on the quality of the image. So the vascular characteristics of the new vessels is displayed with greater clarity. And the retinal new vessels are detected in OCT angiography by the observation of high flow above the level of the ILM. This is fluorescein angiography showing the leakage masking the vessels. Here's the OCT angiography. We can see clearly the details of the vessels and the vitreoretinal interface in the OCT showing that it's protruding above the level, and it's confirmed by the OCT. Also, the recent study showed that the OCT angiography can detect new vascularization very early and more accurate than clinical exam. And of course, it helped distinguish between the new vessels and the irmis. Let's see this one. This is the OCT angiography, and this is the fluorescein, of course. Is it leaky or not? It's protruding above the level of the ILM, so this is a new vessel, not an irma. And this will, of course, has an effective in treating the patients. Regarding ischemia, in fluorescein angiography, of course, it's the non-perfusion areas appears as dark areas, loss of capillaries surrounded by the larger blood vessels. While in the OCT angiography, you can detect where is exactly non-perfusion, if it's in the superficial or the deep vascular plexus. And it's much better delineated, and it gives an improved visualization of the non-perfusion and the foveal avascular zone. We'll talk about that later. And wide field OCT angiography shows comparable results regarding, comparable to wide fluorescein angiography regarding to the non-perfusion areas. However, the non-perfusion areas as seen on the OCT angiography may present capillary occlusion, capillary dropout, or the perfusion deficits, the presence of extremely slow flow or absence of flow within certain capillaries, and they cannot be distinguished or differentiated. Thus, changes in these vessels visualized on OCT angiography images does not necessarily indicate there is no perfusion or an abnormality in the architecture of the vessels. It just may show it's just slow perfusion. For example, in this picture, this is a normal patient having an OCT angiography, and this is a diabetic patient. And the color-coded map with the yellow part showing the area non-perfused. We will see here that in the normal, there is areas marked by the yellow color indicating it's a non-perfusion area, while it's areas with slow perfusion. Regarding the phase, Shihara et al. Suggested that the shape is much better to characterize the phase better than the size, because there's a variation in the size in normal individuals. And of course, the phase metrics can more easily measured in OCT angiography than fluorescein angiography, because it's not obscured by the leakage of the dye in fluorescein angiography. Here, it's much better delineated, and the circularity is a very good indicator for the capillary dropout and macular ischemia. There are several metrics that have been developed for the quantification of microvascular alteration using the OCT angiography. For example, we have, this is the original image. This is when denoising using binarization, and we have here measuring the phase areas, phase circularities, the vessel density, the intercapillary area, and the fractal dimension. All of those are metrics used or computerized in the OCT angiography to automatically measure and detect these changes. These changes can detect diabetic retinopathy before it's clinically detectable, these metrics, okay? And Shao and associates reported a decrease in parafoveal vessel density in eyes without clinically detectable diabetic retinopathy compared to healthy individuals. Also, these quantitative metrics are correlated with the severity of diabetic retinopathy. We have the enlarged phase, the decrease in phase circularity, the lower vessel density, the increase in the vessel diameter index, and the decreased factor dimension, the increased vessel tortuosity, significantly associated with worsening of diabetic retinopathy and visual acuity. So this is a very promising role for OCT angiography as an objective technique for monitoring disease progression in diabetic retinopathy. However, in diabetic macular edema, it has a very low reliability. This is because the accumulated fluid will affect the segmentation capability as the fluid weakens the signal from the deeper layer and give false interpretation. Regarding the choroid vasculature, measuring the choroid blood flow remains challenging using the original dye-based angiography. However, using OCT angiography, it's better visualized and quantified, especially the choroid capillaris. Several studies have been done to measure the choroid capillaris perfusion in diabetic eyes. it was presented as focal and diffuse impairment in the flow in the choriocapillaris. Some reported that there is an increase in choriocapillaris non-perfusion in diabetic patients without clinically detectable retinopathy compared to the control group, while others showed no significant difference. However, OCT angiography has many limitations. Number one, the fluctuating shadows in the RBCs from the superficial vessels may cause an extra flow into the deeper vascular networks, giving a false vessel network. We'll see this in a few minutes. This false image will give, of course, an incorrect interpretation. Another major issue is there is no general consensus in segmentation of the each capillary plexus. Also, since it's based on motion detection, it's particularly sensitive to the patient eye movement, which is a problem in diabetic retinopathy with macular edema. The patient cannot fixate. Of course, the limited fields, it's another limitation for detecting the peripheral vascular changes. And as we said, OCT angiography has a sensitivity threshold, and it only detects the flow above a minimum threshold, also known as the slowest detectable flow. This is, for example, a presence of motion artifact, giving an interrupted blood vessels at the phase area. This is when it's absence of the motion artifact. Of course, this potentially affects the quantitative data we talked about. Another problem is when there's a superficial vessel, this one and this one, it's projected to the deeper vascular plexus, which is abnormal. It's not present in the deeper vascular plexus, but it's shadowed because of the blood flow, as we said. And here we used a function enabled in the OCT angiography to remove this projection artifact. So to take home, the message is that the future of the OCT angiography technology for assessing diabetic retinopathy is promising, and the capability of OCT angiography to detect diabetic retinopathy even before it's clinically detectable may potentially serve as an integral tool in diabetic retinopathy screening. The morphological assessment also of vascular changes has improved our understanding of the pathophysiology of diabetic retinopathy, and the most important is that this quantitative metrics we talked about can objectively assess the retinal microvasculature, highlighting its potential to be used as a standardized and automated, not operator dependent, for detection and monitoring of diabetic retinopathy. Thank you.
Now, Dr. Muhammad Kamal هيتكلم على virtual clinics and artificial intelligence and fluorescein angiography and diabetic retinopathy and diabetic macular edema.
Bismillah ar-Rahman ar-Rahim. It's an honor to be speaking in the AVRS meeting. Today I'm going to Today I'm going to be speaking about one of the earliest investigations that have been used in diabetic retinopathy and diabetic macular edema, the fluorescein angiography, and if it still has a role in diabetics. First, I'll be describing the FFA findings in DR and DME. Basically, the hyperfluorescence in the form of a window defect around an RPE atrophy scar because of laser mark, or anomalous vessel, a microaneurysm. Excuse me, the pointer is not working. A pinpoint hyperfluorescent early, which leaks in the later stages of fluorescein angiogram, or venous beading, which is an irregularity of the caliber of the veins with the staining of the margins of the vein, or an ERMA, I need to be pointing, which is a collateral vessel which can be distinguished from neovascularization by the non-leakage, and it occurs mainly as borders of area of non-perfusion. The neovascularization, number 4, where there is anomalous vessels that start to leak early, and this leakage is increasing in intensity and size along the phase of angiogram. We can also have leakage in the form of staining of the fibrovascular fibrosis in diabetic and advanced diabetic cases, or in a preformed space as occurs in the cystoid spaces in cystoid macular edema. or hypofluorescent lesions due to a vascular filling defect, as occurs in cotton wool spot, where this infarction of the nerve fiber layer is corresponding to area of vascular filling defect, or an area of capillary non-perfusion, where there is area of darkening surrounded by the occluded vessels, or a blockage from a pre-retinal hemorrhage or vitreous hemorrhage in front of the retinal vasculature, or interretinal hemorrhages and the hard exudates. And the interretinal hemorrhages, the blood hemorrhages, can be differentiated from microaneurysms only through the fluorescein angiogram by being hypofluorescent, or a subretinal hemorrhage and the RPE hypertrophy, where there is blockage of the choroidal fluorescence. So overall, fluorescein angiography is a valuable tool to support and enhance, but does not replace the standard clinical examination. Albeit there is only one exception to this rule, as a densest asteroid hyalosis, which is a finding more common in diabetics. The clinical assessment may be obscured by these opacities. However, on fluorescein angiography, we can delineate the characteristic stage of diabetic retinopathy. The ETDRS in their report 11 in 1990, they started to use the FA in classification of diabetic retinopathy using classifications is very similar to that my colleague Rahma Mitwali said, by commenting on early mid-phase, assessing the fast zone, the capillary loss and the capillary dilatation, and the late phase assessing leakage and leakage source. And they have the same classification as mild, moderate, severe, and PDR. However, this staging was tedious and it's time-consuming. A more useful use of fluorescein angiography in diabetic maculopathy, where it can be classified as focal leakage maculopathy, where there is late leakage from individual or cluster of microaneurysms, or maybe a diffuse leakage maculopathy, where there is no culprit microaneurysm causing this leakage, and it is assumed to be generalized dilatation of capillary bed. And the cystoid macular edema is one type, specific type of this diffuse leakage, giving a petaloid pattern in fluorescein angiography. The more useful finding in FA is the ischemic maculopathy, which represents a closure or non-perfusion of perifoveal capillaries. This ischemic maculopathy can explain the poor vision in patients showing no significant macular findings. And it was found that it corresponds to the degree of retinopathy. That is, if a patient has a severe macular ischemia, he may very soon develop PDR. It is characterized by presence of multiple cotton wool spots and blood hemorrhages. There is also a mixed pattern where there is an early large area of ischemia followed by late leakage, diffuse leakage, a mixed leakage ischemic maculopathy. Also, the ETDRS started to try to classify this or grade this ischemic maculopathy using 3 parameters: the capillary loss, the phase size, and the phase outline. The capillary loss is compared to standard photographs. The phase size is measured by the innermost or the shortest diameter of the phase, and the phase outline is outline of the phase margin. Generally, there is irregularities of the phase margin, abnormal tortuous capillaries budding into phase, terminal arterioles ending abruptly into phase, enlargement of intercapillary spaces, and the shortest diameter is more than 500 micrometers. Generally, we can use the fluorescein angiography to classify ischemic maculopathy into mild if there is less than half of the phase outline showing irregularity with intercapillary space increasing, or severe if more than 3/4 or half of the capillary outline is abnormal. The new advances in FA and diabetic retinopathy, as my colleague Dr. Mohammed Ashraf said, is using the ultra-wide field FA, where by screening nearly 200 degrees of the fundus, many cases of mild to moderate or non-proliferative PDR can be classified as PDR due to far peripheral lesions. A new advance in FA is the automated vessel density detection, where a high-resolution FA image can be processed using computer program to detect vessels and then highlight these vessels increasing its contrast, so leads to better evaluation of macular perfusion and macular ischemia. So overall, does the FA still have a role in DR and DME? Yes, I think so, because of it gives an assessment of ocular and retinal perfusion through arm retinal circulation, arteriovenous passage, and retinal circulation times. It differentiates blood hemorrhages from aneurysm, so will be implicated in staging. It detects diabetic retinopathy earlier, especially on wild field, and detects areas of non-perfusion and risk of neovascularization, especially on wide field. And it also detects NV, NVD, and their extent on wide field. In regards to maculopathy, it gives a good classification or assessment of the type of maculopathy and the grade of macular ischemia with implication on visual prognosis. At last, it assesses the effect of treatment as regression of NVE on VD after doing laser photocoagulation. This is the first talk. The second one, sorry for the increase in time. It's about virtual clinics and artificial intelligence. I will be speaking about just definitions and to introduce these ideas to our audience, if you please. In the era of COVID, there is a very huge need for such virtual clinics to remove the face-to-face consultation. It's either synchronous or asynchronous. Asynchronous virtual clinic means that the patient and the doctor are at the same time communicating with each other, discussing the management and diagnosis, or asynchronous where the physician can review the patient's data in a later time and gives his opinion to be processed. One of these techniques is using OCT image and visual active measurements collected by nurses or technicians to be later reviewed by ophthalmologists. By this way, twice the number of patients can be assessed. Also, the data acquisition can be outside of normal clinic hours, so increasing the capacity of the healthcare system. And it was found by evidence-based medicine that OCT triage reduces the inappropriate referrals and is cost-effective. This is especially important for healthcare systems which employ the diabetic retinopathy screening as referable cases and non-referable cases, so to decrease the inappropriate referrals. This is a diagnostic hub of how a virtual clinic works in NHS, where there is a focused history followed by visual active assessment and IOP measurement taken by a nurse or a machine or a technician, and then imaging either through an OCT pathway, where the patient has an OCT and two field fundus photographs, or a wide field pathway, where the patient has an OCT and a wide field image. And then these images are assessed. If there are any red flag, then there is a same day-to-day face assessment and treatment. If there is no such red flag, so we may use a virtual asynchronous assessment with one of the following outcomes, either the OCT pathway, the wide field pathway, the face-to-face clinic, laser clinic for laser therapy, or retinal therapy unit for anti-VEGF treatment. The last part of my talk is about artificial intelligence in diabetic retinopathy and diabetic macular edema. Basically, artificial intelligence is the way any technique which enables computers to mimic human behavior. A subcategory of this AI is the machine learning. A machine learning differs from the routine programming of computer programs is that we do not teach the machine every aspect of its program. However, we give the machine data to get an experience, and then the machine itself finds the way it interprets further data and reach a conclusion. A subset of this machine learning is deep learning, where there is a multi-layer neural network occurring in this machine learning to identify complex features from data the same way the human brain works. These neural networks are termed convolutional neural networks. It's a series of algorithmic attempts to identify relationships in a set of data by using a process that mimics the way the human brain operates. As shown in this photo, the machine is given training photographs of fundus photo with the grades done by humans, and then these computer programs identify different elements, different data components like hemorrhages, exudates, ERMAs, MVEs, to learn how to detect these findings in further data, further fundus photos, and to reach an assessment or clinical decision. The process flow is as follows. The input is a retinal image. Then the neural networks acts through a black box that we don't know in exactly what does the machine think. However, the machine then sends an output or a classification. This output is compared to the ground truth, which is the human grading of the training data set. When this process is repeated to reach a very high standard of specificity and sensitivity, then the machine is tested on a test data set to assess its accuracy and reproducibility of classification or staging. Landmarks occurring in this area is, in 2016, a large data set, nearly 100,000 images from a US university, was publicly available for many research communities and many universities to use in developing their own AI systems. These are graded images of diabetic retinopathy by certified graders, and the AI systems try to train itself to further classify images. In 2016, DeepMind, which is a subsidiary of Google, announced a research partnership with Moorfield Eye Hospital to apply these concepts in real life in the NHS. And in 2018, the FDA approved an AI-based medical device, the IDEX-DR, with its improvement, IDEX-DR version 2, reaching a specificity of 96% and a sensitivity of 87% in detecting diabetic retinopathy changes and classifying the diabetic retinopathy changes. This is the picture of the machine operated by a nurse or a technician at a primary care unit or in diabetes clinic. The machine, through fundus photographs, can detect and classify and takes the next decision, either negative for mild or less diabetic retinopathy, or referable cases, or vision-threatening cases, or low image quality to be repeated or to be examined through an ophthalmologist. Many countries have adopted similar AI systems for their diabetic retinopathy programs, including our university. We are now cooperating with the engineering faculty to develop an AI system for diabetic retinopathy screening based on our dataset and on the public available dataset. Thank you.
Dr. Tarek Hamida will present diabetic retinopathy in children and young adults.
مساء الخير. I would like to thank the opportunity of the organizing committee for letting me speak about an interesting subject which is has some clinical implication in our practice, and I hope in the next 10 minutes to change our ideas about how to manage children with diabetic retinopathy. First, when Professor Dr. Ahmed Abdelhadi texted me preparing a presentation about diabetic retinopathy in childhood and young adults. I thought, why this special entity? Why choosing this group of age? So I started to search the literature about them. Interestingly, I didn't find a lot dealing with such patients with young age. Most of the large-scale diabetic retinopathy studies include patients above 18 years. And most of the paper published according to this age is published in pediatric journals or in epidemiology journals. No specific papers dealing with the clinical entity with these patients. So I will try to figure out why this one. Why choosing this group? Perhaps this study can answer this. This is a study done in North England where they searched for a screen for epidemiology of the diabetic retinopathy in children younger than 12 years. And interestingly, they found that they are mainly type 1 diabetes. Only 2% of their search was type 2 diabetes. And this is the importance of this is the key how to think in this age group. Because it is known that type 1 diabetes is genetically determined. And the genetically determined diabetic retinopathy, as shown by Dr. Ahmed shortly, that can lead to microvascular abnormalities, whether in the eye, whether in the kidney, whether neuropathy or something like that. So type 1 diabetes are more prone to complications than type 2. Interestingly, the incidence of type 1 diabetes is increasing in our country. Here in Egypt, this was done in the Delta, and we find that the incidence of the diabetic in the type 1 diabetes is increasing. So we're in Egypt here facing a problem dealing with more and more children with diabetic retinopathy. So why thinking in this way? Why thinking in type 1 versus type 2? This study done in Spain shows that the incidence of the diabetic retinopathy is much higher in type 1 than in type 2. And the sight-threatening diabetic retinopathy is almost twice the fold in type 1 than in type 2. But interestingly, the diabetic macular edema is equal in both groups. So we are facing more proliferative process than dealing with macular edema in such age group. Another important factor that the long duration of the diabetes in type 1 more than the long duration in diabetes in type 2. And this we know that the diabetic retinopathy needs time to progress. Also, the bad metabolic control in such patients, usually children, have a higher level of hemoglobin A1C, and that implicate on the progression of diabetic retinopathy. But this study showed an important data. We should stop at it. Whether the type of diabetes, type 1 or type 2, 15% of the cases developed diabetic retinopathy before 5 years of follow-up. So when fashioning a screening program, 5 years is not suitable for detecting early such case. So in our guidelines in the EGVRS screening program for type 1 diabetes, we delay the first examination of these group of type 1 diabetes for 3 to 5 years from the incidence, contrary to the data that's published in the paper. Not only us, but most of the authorities do this, except the pediatric authorities, where they put a cut age of 9 or 10 years of starting your screening, regardless the period lapse from discovery of diabetes. So if you have a child who's 10 years, you should start screening at this age, and this is proper, as we will see. Perhaps the youngest age of published about the development of diabetic retinopathy was published by Hall, 5.5 years. But fortunately, the diabetic retinopathy was mild, non-proliferative in such age. So we can have diabetic retinopathy in a very young age. But what the Wisconsin epidemiology study tells us, it tells us that the prevalence of diabetic retinopathy in group age from 10 to 14 years is only 2%. That increases to 10% from 15 to 19 years. And the youngest age of sight-threatening diabetic retinopathy was 15 years. So the duration of the puberty is a cut edge for rapid development of the process. So in patients who has diabetic retinopathy before puberty, they show excess 30% of developing sight-threatening diabetic retinopathy in longer age. So when you have a child reaching puberty, you should examine him properly for detecting more complications that is going on. Another important study with the National Pediatric Diabetic Audit shows that girls are more prone to develop diabetic retinopathy than boys. And this risk of developing sight-threatening diabetic retinopathy increased by age of 18 to reach up to 30.5%. And they tried to figure out why the process increased at that age. The process increased at that age because of increase of growth hormone, increase of insulin-like hormone, growth factor, 6 hormones, and usually at that age, those poor child develop elevated blood pressure. How can I screen for presence of diabetic retinopathy in my practice, in my clinic? First of all, I should have a dilated fundus examination of this child, grading them whether mild, non-proliferative, moderate, severe, or even proliferative diabetic retinopathy. Another important thing with the detection, with the stereoscopic fundus examination, to detect macular edema in these childs. And we have what Ahmad Ashraf al-Masri just told us, the magnificent wide field imaging. It carries in children both non-mydriatic imaging, so you will not annoy the child, and you can, with just a snap, you can go to the vast periphery to search for any diabetic changes in the child with that magnificent camera. So it is a tool that is coming on to screen our babies. Another important issue, if the patient needed fluorescein angiogram, so go for fluorescein angiogram, which is not that easy in pediatric practice. And I remember that in young children, I used to give them the dye to drink them, sacrificing the transit in these patients because they are panicked, they are afraid of prick, they are afraid of many things. Another important issue is that you should examine thoroughly retinal periphery, because the process in this child, in my practice, majority of them have a peripheral lesion with a normal central area, like this child. So don't miss the periphery. Even with your fluorescein angiogram, you may find catastrophe at the periphery with a normal central field. Another important issue is the presence of the using of the OCT to detect non-centrally involving macular edema or centrally involving macular edema. With the new tool of the OCT angio, we are in hope to replace the dye, which we are fearing of the break for the child, to detect new vessels, such in upcoming days. Also, we can detect the flow at the macular area, whether at the level of the superficial plexus or deep plexus, as nicely Dr. Kharbush shows us in a short time. So we will have an idea about the vasculature of the macular area of our child. Regarding management of this diabetic retinopathy in children, it doesn't differ that much about, with the adult one. So you can go for PRP in these children for proliferative diabetic retinopathy, but take care. You should be aggressive in your treatments because it is a sight-threatening, and they develop sight-threatening diabetic retinopathy in short time. On doing PRP, you should be aggressive, reaching as far periphery as you can to go to stop proliferation in such young age. Also, treating diabetic macular edema is a questionable issue, whether to use anti-VEGF safely in a child or not. Till now, we don't have a large-scale volume study telling us whether it is safe to use anti-VEGF or not. But we all know that we can use safely Avastin in children with ROP. And also, ranibizumab has been tried in children with secondary CMV safely. But actually speaking, there is no large-scale study telling us safety of usage of anti-VEGF in children. On the other hand, I wouldn't prefer using corticosteroid or trimethylone acetanoid in such an age group because of the complication of the corticosteroid in such a young child. To summarize that, diabetic retinopathy has been well described in children, and although the majority of affected patients do not develop vision-threatening retinopathy after age of teenage, diabetic retinopathy screening should be carried out at pubertal age. At that age, patients are more prone to develop rapidly progressive diabetic retinopathy. Diabetic retinopathy in children and young adults should be detected early and treated aggressively for the fear of irreversible blindness. And also, examination of retinal periphery is mandatory to detect peripheral diabetic changes that may precede central retinal involvement. And lastly, the safety and efficacy of intravitreal anti-VEGF therapies in children and adolescents with diabetic macular edema has not been established. However, ranibizumab has been off-label used to treatment of retinopathy of prematurity. There are some limited data on the usage of ranibizumab in adolescent patients for the treatment of choroidal neovascularization. Thank you for your attention.
آخر توك في الجلسة دي الدكتور تامر موسى هيكلمنا على الدايابيتك ريتينوباثي اند بريجنانسي.
بسم الله الرحمن الرحيم. Thank you for this opportunity. حابب أشكر دكتور أحمد مجدي دكتور أحمد عبد الهادي for this invitation. My talk today is diabetic retinopathy and pregnancy, and whether do we deal with the pregnant females who are diabetics the same way that we are dealing with normal nulliparous females. First of all, as we all know that the prevalence of diabetes mellitus is increasing in all categories. In the young age, as Dr. Tariq Hamida said, and in the older age, type 1 or type 2 diabetics. So we are expecting to have more diabetic females who are coming. But fortunately, most of these diabetic females, they are actually gestational diabetes. With these gestational diabetes, they have no such danger of developing diabetic retinopathy, except if these females, of the small proportion that we have undiscovered type 2 diabetes before the onset of pregnancy, so progression of diabetic retinopathy in these patients are more common. So, which is more affected, whether type 1 or type 2 diabetics? Actually, type 1 diabetics is more affected with diabetic retinopathy and its progression more than type 1. Okay, according to the Diabetes in Early Pregnancy Study, which is one of the largest studies that investigated effect of diabetes in all aspects of pregnancy, the progression occurs according to the baseline diabetic retinopathy with the onset of pregnancy. For example, if the patient had no existing diabetic retinopathy, the risk of progression is about 10%. This increased with mild non-proliferative to 18%, moderate to severe to 54%, and in proliferative cases up to 63%. How the progression is defined as Muhammad Ashraf al-Masri said, as two-step or more worsening according to the modified early house diabetic retinopathy classification that is used early in the ETDRS studies. So, when do progression occurs? Actually, progression occurs as early as the first trimester. Till when? Is it till the end of the pregnancy? Till labor? No, actually the progression may continue up to the first 3 months in the postpartum period. Okay, some regression, yes, after this period, some patients do what we call regression. 1 year in the postpartum period, they return back to the pre-existing or the baseline diabetic retinopathy level, which what we call the metabolic memory of these pregnant females. Progression of diabetic retinopathy is more common, as we said, in the type 1 diabetics. Okay, what are the risk factors? If the risk factors that well known as the duration of diabetes, for example, yes, the type 1 diabetic, they put a cutoff point of 15 years. More than 15 years, the progression is 38%. Less than 15 years, the progression is about 18%. But this is not the main risk factor. The main risk factor, as we said, is the baseline diabetic retinopathy. And this highlights the importance of controlling of diabetic retinopathy before the onset of pregnancy in order to control the progression of the diabetic retinopathy in pregnant females. Poor glycemic control, of course, but here the glycemic control or the poor glycemic control has no impact only in diabetic retinopathy. No, it has an impact on the incidence of preeclampsia or renal failure with pregnancy. Hypertension and preeclampsia by itself, yes, it play a role in the progression. With about 25% of those who progress, they are normotensive, 60% they have chronic hypertensive, and 50% they have pregnancy-induced hypertension. Nephropathy occurs, it also plays a role. So what is the pathophysiology of these cases? Why, especially in pregnant females, do progression of diabetic retinopathy occurs? The pregnancy, as we all know, there is associated with increase in the cardiac output and decrease in the peripheral resistance. So there are more and more fluid and more blood is going to the retina. But actually, this will lead to increase in the endothelial damage and the pericyte loss of the retinal blood vessels, so with increasing exudation and macular edema. Again, if we got increase in the cardiac output or the retinal vasculature, what will happen? There is a corresponding vasoconstriction of the retinal arterioles, and this will lead to hypoxia at the capillary level, and this will increase the risk of hypoxia and progression of proliferative diabetic retinopathy. Again, there's increase in the other growth factors which are present that mimic the action of the vascular endothelial growth factors, such as insulin growth factor 1, placental growth factor, endothelin, and fibrovascular growth factors. All of these, they play a role in the metabolic or the chemical theory of diabetic retinopathy. So, diabetic macular edema of pregnancy. Do we go for anti-VEGF injection? Actually, patients that progress do macular edema either in type 1 diabetes or type 2 diabetes. However, again, more than 88% of cases, they actually do regression of the diabetic macular edema with the 1 year postpartum period. 88%, yes, from every 100 diabetic pregnant females, about 90 of them, they actually go back to their original level without any treatment. So, do we need for investigations in patients with pregnant females with diabetes? Yes, of course, we do. We go for OCT and OCT angio. Never mind about this. Or how about the fluorescein? Do we inject fluorescein? Actually, fluorescein, yes, do pass the blood placental barrier and it passes through the breast milk. So it's well known that it reaches the baby. It can actually be recovered from the fetal circulation. So, but actually we do not need to do fluorescein. Why to do fluorescein? All of the studies, they actually use a serial of photographies in order to classify the diabetic retinopathy of pregnancy. Actually, there is no need to do fluorescein angiography in diabetic pregnant females. So, What is the treatment? Do you go, what is the main treatment? Yes, the main treatment is the pan-retinal photocoagulation, and we do pan-retinal photocoagulation in severe non-proliferative diabetic retinopathy and proliferative diabetic retinopathy, preferably before the onset of pregnancy, in order to control that pathology before pregnancy or before pregnancy actually occurs. But on the scale that I say to my patient, we can augment this laser for during the pregnancy, because there is a progression that may occur. Yes, we can augment it during the course of pregnancy. Actually, patients who succeed to go for complete resolution or actually to complete control of the proliferative activity, they are not reported that there is any evidence of progression if you got complete control of the proliferative activity. So, how is anti-VEGF? What is the use of anti-VEGF? Do we use anti-VEGF for macular edema? As we said, about 90% of those who develop macular edema during pregnancy, they will have spontaneous regression by 1 year after the onset or after the postpartum period. So, no anti-VEGF is reported to be used or safely be used in pregnant females due to fear of the teratogenic effect. Actually, with exceptions of, do we deal with the macular edema in diabetic in pregnancy? No, we don't deal with it, except if the patient has very severe progression of diabetic macular edema or severe lipid exudation in early pregnancy. So I don't wait for about 9 months in order to start my treatment. Here the treatment is either focal laser, if you do it, or corticosteroids. What are the corticosteroids used? You can go for preservative-free triamcinolone and the dexamethasone implant, such as Ozurdex. They are safe. Yes, they do not pass to the fetal circulation. No reported about the teratogenic effect. So, to sum up, I will sum up according to the recommendation of the management of diabetic retinopathy in pregnancy. It needs close collaboration between obstetrics, endocrinologists, and ophthalmologists in order to deal with this condition. Counseling regarding the effect of pregnancy of diabetic retinopathy. Glycemic control, it should be optimized, and it should be optimized before even pregnancy occur in order to control the glycemic impact. Increase the screening, of course, during pregnancy. Screening in the postnatal period, you should screen the patient not only just upon delivery. No, you should continue for 12-month postpartum period in order to see the regression or the progression of the diabetic retinopathy that may occur. Those with gestational diabetes should be followed, of course, so as they do not develop later on type 2 diabetes mellitus after the delivery. Severe non-proliferative or worse, they should go for PRP in order to prevent their progression. About 50% of these may progress to proliferative activity. The best treatment for progressive DMO, only progressive in order certain circulation situations, is to injection of steroids. The question that is diabetic retinopathy, it should be a contraindication for vaginal birth? No. Theoretically, there is an increased risk of vitreous hemorrhage with vaginal delivery, but it is not reported in any study that diabetic retinopathy is a contraindication of vaginal birth. Thank you so much.
Thank you for the first sessions. Thank you, Dr. Said Gaber, Dr. Yusri Hatata. Now we'll invite you to the second session, current concept and treatment. We will invite Professor Dr. Fadil Aboushoucha and Professor Dr. Muhammad Ragab as a chairperson.
الو دكتور فاضل، اتفضل سعادتك. مساء الخير يا جماعه. لو تسمحوا بس احنا هنضطر في الجزء الجاي ان احنا نقلل دقيقتين في البرزنتيشن تايم، فنرجو الساده البريزنترز يحترموا الطلب، عشان البرنامج طويل شوية فمش هينفع ان احنا نمشي بالريت اللي احنا ابتدينا بيه.
Okay, Bismillahirrahmanirrahim. I would like to thank Dr. Magdi and Dr. Ahmed Al-Hadi for the invitation. And today our talk about the anti-VEGF in DME. First, I believe that the history of anti-VEGF is a successful story, which is almost comparable to standing on the moon. In 1940, Michelson proposed that any ischemic retina release a material which is named factor X, responsible for the new vascularization of the retina and the anterior segment of the eye. 50 years later, it was demonstrated that normal vascular growth is secondary to a production of vascular endothelial growth factor from the pituitary follicles in bovine animals. And 2 years later, it was hypothesized that this factor X that was proposed by Michelson is the VEGF, which was confirmed in 1994 by the American Journal of Pathology. And in 1997, this was the first anti-VEGF to be produced for the oncology purpose to treat vascular growth, to treat cancer colon. And in 2004, the FDA approved this production of the Avastin or the bevacizumab for the oncology purpose. And in the same year, pegaptinab was produced and received an FDA approval for the treatment of wet AMD. Actually, the pioneer for this kind of treatment is Dr. Philip Rosenfeld, because he was the first man to try to treat wet AMD patients that has no hope at that time by injecting those patients, which were 18 patients, and this study was funded by the patient in Bascom Palmer's Eye Institution. And at that time, bevacizumab was received as an intravenous injection every 2 weeks by the dose of 5 milligram per kg. And at the same year, there was a red flag from the FDA that this drug causes a thromboembolic manifestation, but that was for the oncology treated patients and was not reported in the study ran for the ophthalmology purpose. After that, he ran the first small or pilot study using the intravitreal injection of bevacizumab for the treatment of wet AMD, diabetic macular edema, and vein occlusion. And it showed a great and remarkable improvement, whether anatomically or functionally. And at that time, it was already known that the VEGF family includes multiple VEGF subtypes, but it was also known that VEGF-A is the most responsible factor for the angiogenesis and the vasodilatation leading to vascular permeability and causing the diabetic macular edema, together with the placental growth factor later identified. And there was 3 main receptors for the VEGF, which is VEGF receptor 1 and VEGF receptor 2. And those are responsible for the mechanism of VEGF-A, responsible for the stimulation of angiogenesis, increased permeability, and the chemotaxis for inflammatory cascade, leading to the sprouting of angiogenesis after an intracellular cascade of events. At that time, we had, in 2004, we had the Macugen, which is an RNA aptamer, only blocking the VEGF-A165, which is the most abundant VEGF subtype, and it has a intraocular half-life of 4 days only, and it was injected every 6 weeks. At the same year, or 1 year later, after the study ran by Rosenfeld, Avastin was started to be injected, and it shows a marvelous improvement in the vision and in the OCT, with a full humanized monoclonal antibody of a molecular weight of 149 kilodalton, and it stayed in the eye around 6 days with the intraocular half-life, and it was injected in 0.05 milli every month. Later on, the same company started to produce what is called the ranibizumab or the Lucentis, which is a mutagenized monoclonal antibody, including only the antigen binding fragment of the Avastin molecule. And it has definitely a smaller molecular weight, but it has a longer intraocular tissue half-life because of its less systemic absorption and clearance. 5 years later, Regeneron started to produce what is called the aflibercept or the Eylea, and it has a different mechanism of a fusion protein blocking both the VEGF receptor 1 and VEGF receptor 2, as well as the placenta growth factor, which was responsible for also angiogenesis, as we saw. In 2002, there was a collaboration between the National Eye Institution and the Diabetologist Eye Institution in USA to run what is called a DRCR network to deal with diabetic affection for the eye regarding diabetic retinopathy, diabetic macular edema, and other conditions affecting the vision of the patient. And since that time, the diabetic retinopathy has established an evidence-based guidelines for every scenario that we can meet in diabetic patients. Regarding the injection of any drug inside the eye, we have different methods of injection nowadays, but most of the eyes are eliminated from the eye, whether through propagation to the anterior chamber and then diffusion to the systemic circulation, and this is the main way of elimination of anti-VEGF from the eye because they have large molecular weight, and a small amount that can penetrate the retina are excreted through the circulation to the serum. So by now, we are looking not just for an anti-VEGF, but we are looking for the optimum anti-VEGF, which means that it has a longer duration of action and a high VEGF binding affinity. And this could be done by dose escalation of the intravitreal injections or increasing the molecular weight, as we are going to see what the new molecule called the KSI-301, and they rendered this the largest molecular weight of any anti-VEGF whatsoever. Or even decreasing, which is the opposite idea, decreasing the molecular weight of anti-VEGF as the Beovu or the pralucizumab, and we are going to discuss it later, or through the new technique of port delivery system as a slow release of the drug. So now, after 10 years almost or more of the production of the first anti-VEGF, they started to lose what is called their patency. So other biosimilar materials and the new anti-VEGF are now on the market. The first one was the Combercept, and it is used heavily in China since 2013. And it is the biosimilar of aflibercept, which is a fusion protein that can block the VEGF receptor 1, VEGF receptor 2, and the prostaglandin placenta growth factor. And they claimed that due to a change in the domain 4 of the extracellular part of this anti-VEGF, it has a higher affinity than the aflibercept, which can render it a longer duration inside the eye. And they are waiting for its FDA approval this year and to be in the market in the next year. And they ran a study called the Sailing Study in 2014, comparing the safety and the efficacy of the Combercept versus laser in diabetic macular edema, and they have the year 1 and year 2 study. In year 1, it shows by far that the improvement in the vision was significantly high compared to the laser group. And in year 2, which is the extension, those that were receiving laser were allowed to receive also Combercept, showing that the both arms reached the same endpoint by the second year. And they concluded that Combercept at that time is very safe and effective treatment compared to the laser for the management of diabetic macular edema. The second molecule is called Absipar-Bigol, which is a new anti-VEGF made of protein connected, which is called the DARPin or designed anacrene repeat protein.
مصطفى انت عديت كده الوقت اللي مسموح لك؟
Stop. Okay.
متأسف بس يعني شكرا جزيلا مصطفى. وحابب اقول لك ان احنا في اسكندريه اول ناس حققنا الافاستين كان سنه 2007.
تمام. انا كنت اكتر حاجه عايز اتكلم عليها ان في دلوقتي الفارسيماب ده لسه FDA approved 1 week ago. وانا I think it's the future in the faricimab because it's going to work on the VEGF and the angiopoietin 2 blockage. And the study was published 1 week ago, the 24th of January, showing in diosmid and Rhine that the duration or the interval between the injection can be extended in diabetic macular edema up to 6 months after the initial loading dose. And another message that the adverse event was reported by the American Academy that any anti-VEGF injection that is responsible for any thromboembolic manifestation under in the follow-up period of 10 years, there was no any significant risk with the anti-VEGF compared to laser or the corticosteroid injections.
هناخد دكتور مصطفى أسامة نجار كلامنا عن الستيرويدز in diabetic macular edema. يا ريت يا أسامة تاخد بالك من الوقت. ها
السلام عليكم جميعا. My talk is about the role of steroids in treatment of diabetic macular edema. As my dear colleague Dr. Mustafa mentioned, that intravitreal anti-VEGF is the treatment of choice for treatment of diabetic macular edema. However, there is a proportion of patients who do not achieve optimal response to anti-VEGF. And we have a big evidence for this from previous studies. For example, post-hoc analysis protocol T, which was a head-to-head comparison between the 3 anti-VEGF, it demonstrated that after 6 injections of intravitreal anti-VEGF, focal laser treatment was indicated in 41% of eyes treated with aflibercept. Laser treatment also was indicated in 52% of patients treated with ranibizumab, and laser treatment also indicated in 64% of patients treated with bevacizumab. Also, we have evidence from post-hoc analysis protocol I, which demonstrated that after 3 injections of intravitreal ranibizumab, we have around 40% of eyes that showed suboptimal response. And those patients with suboptimal response, those that gained less than 5 liters after 3 injections, but continued to inject every 4 weeks, even for 1 year, approximately 28% of those patients responded well after 1 year of monthly injections. And this was true also for 3 years. This means that we have 2/3 of patients that will not gain a lot of vision even with monthly injection for 1 year. So there is a price paid to be paid if for not selecting the appropriate therapy for in a timely fashion. We know that it is believed that diabetic macular edema may evolve from a primarily permeability-driven disease that responds to anti-VEGF or may respond to steroids. Steroids act by several pathways. In pathogenesis of diabetic macular edema, it reduces the action of inflammatory cytokines and reducing VEGF. It reduces electrostasis, improve other physiologic and structural changes such as tight junction integrity. We have steroids that have been extensively evaluated for treatment of diabetic macular edema, including intravitreal triamcinolone acetonide, dexamethasone, and fluocinolone acetonide. I will speak about the clinical trial evidence for intravitreal triamcinolone acetonide for treatment of diabetic macular edema, and my dearest colleague Dr. Mohammed Samir will speak about slow-release devices such as Ozurdex and Iluvan. Triamcinolone acetonide is a synthetic steroid formulated as injectable suspension. It has a 7.5-fold higher anti-inflammatory potency than cortisone. It is water insoluble, so it remains in the vitreous for a much longer time than other steroids, which eliminated within few days. We have a commercially available triamcinolone acetonide in 3 forms: Trivaris by Allergan, Kinacort and Kinalog by Bristol Myers Squibb. Steroids, intravitreal triamcinolone was first reported for treatment of age-related macular degeneration, and some years later it was also used for treatment of diabetic macular edema. 2001, the first reports of isolated cases for treatment of diabetic macular edema with triamcinolone were published, suggesting some effectiveness, so it was considered important to conduct a randomized clinical trial. The Diabetic Retinopathy Clinical Research Network conducted Protocol B and investigated the use of intravitreal triamcinolone versus laser treatment for cases of diabetic macular edema. This study was conducted on 840 patients divided into 3 groups. The first group receiving laser treatment, the second group receiving intravitreal 1 mg triamcinolone, and the third group receiving 4 mg intravitreal triamcinolone. And the visits every 4 months through 3 years, and the primary visual outcome was at 2 years. As we can see, after 4 months of treatment, the group received intravitreal 4 mg intravitreal triamcinolone have a significant visual acuity gain. Through follow-up at 1 year, there was no significant difference between the 3 groups. At 2 years of follow-up, we can see amazing, the laser treatment has a significant visual acuity gain above the intravitreal triamcinolone, either 1 mg or 4 mg group. And so this study conducted that focal laser treatment has a greater long-term benefits compared to intravitreal triamcinolone in patients with diabetic macular edema. In addition, it has a less adverse effect, such as increased diopia and cataract. This difference was not considered attributable to the development of cataract, since the results were consistent when analyzing pseudophakic patients. At 3 years, the patient receiving 4 mg triamcinolone had a much higher incidence of cataract, 83% versus 31% in laser group, and higher incidence of IOP rise in 31% versus 3% in laser group. Only subgroup of patients with severe visual acuity from baseline have a better visual acuity gain in intravitreal 4 mg triamcinolone group. However, this number was too small to draw a meaningful conclusion. Also, Diabetic Research Network assessed the use of peribulbar triamcinolone for treatment of diabetic macular edema. They conducted Protocol E. They compared laser treatment versus peribulbar steroids, and the study question is that is posterior or anterior subtenuous steroids have a beneficial effect versus laser treatment in diabetic macular edema, and the study was either to inject anterior subtenon 20 mg triamcinolone or posterior subtenon 40 mg triamcinolone versus laser and versus combined treatment. The main visual outcome was visual acuity and central macular thickness measured by OCT. We can see that at the end of the study, at 24 weeks of treatment, there was no significant difference between the 5 groups. So this study concluded that peribulbar steroids are unlikely to be of benefit in treatment of diabetic macular edema. Also, Protocol I has compared triamcinolone versus ranibizumab and laser treatment, and the end result is that ranibizumab plus deferred or prompt laser treatment has a superior visual acuity gain in comparison to triamcinolone. As regards the safety of steroids, we have an incidence of complications such as post-injection ocular hypertension. We have 28 to 42% of increased IOP. This condition usually controlled by medical treatment, and 1% of those cases may require filtration surgery. IOP rise start about 1 week after injection, and they return to baseline nearly after 8 months. Comparing studies using different doses of triamcinolone for intravitreal injection shows that the higher the dose, the longer the duration of effect of steroids, and the higher incidence of ocular hypertension.
Dr. Osama.
Okay.
in conclusion,
my take-home message is that intravitreal injection may be a therapeutic option for treatment of diabetic macular edema, especially in pseudophakic patients and in patients with suboptimal response to laser or to previous anti-VEGF injection. And the majority of problems with steroids is used related to high intraocular pressure and the cataract. Drug delivery system may be of value in reducing the number of injection, and this issue will be discussed by my dearest colleague Dr. Muhammad.
شكرا دكتور أسامة. متشكرين جدا يا دكتور أسامة وأسفين على المقاطعة. دكتور محمد سمير ديليفري استراتيجيز.
بسم الله الرحمن الرحيم. قبل ما ابتدي انا احب طبعا اشكر دكتور مجدي على السبورت اللي بيدوه لنا دايما والانسبيريشن ان احنا نكمل ونعمل نكيب اون ميكينج الكونتينيوس ميديكال ميتينجز بتاعتنا. واشكر طبعا كل زمايلي في البورد اوف ذا AVRS. انا ان شاء الله هتكلم النهارده على الدراج ديليفري سيستم. احنا ليه النهارده why we are talking about the drug delivery system? In order to increase the patient compliance, potentially decrease side effects from repeated monthly injections, and improve outcomes. Those strategies include the development of drug with longer treatment interval, sustained drug delivery, and implantable drug delivery system. The advantages of ocular drug delivery system: increase accuracy of dosing, نتحكم في الدوزنج, overcome the side effects of repeated injections, provide sustained and controllable drug delivery, improved ocular bioavailability of drug by increasing the corneal contact time, provide targeting within the ocular globe and prevent drug loss, circumvent the protective barrier like drainage, lacrimation, and conjunctival absorption, and to provide comfort, better patient compliance, and improved therapeutic performance of the drug, and providing better housing of the delivery system. This is the first delivery system, was in 2014, the PMP, which is the implantable micropump for drug delivery in patients with diabetic macular edema. The safety and surgical feasibility of the first in-man ocular implant of a novel posterior micropump drug delivery system in patients of diabetic macular edema. The PMP, pre-filled with ranibizumab, was implanted into the subconjunctival space. After implantation, the PMP was wirelessly controlled to deliver a programmed microdose. Comprehensive ophthalmic exam and optical coherence were performed biweekly for 90 days. The duration of this implant, the PMP, is 90 days. They conducted a study on 11 patients and explanted after the 3 months. This is the schematic presentation of the PMP. It's like the valve. The blue arrow indicates the intraocular cannula, the red arrow indicates the refill port, and the black arrow indicates the body of the PMP that contains the sealing package. And this is 2 pictures of the PMP slit lamp picture at 20 days in picture A and at 90 days, and all subjects had a standard healing process after the surgical implantation that improved over time. The PDS, which is the port delivery system, it's from Roche, and it has FDA approval in 2021 in the United States. It has gone through 3 clinical trial phases, phase 1 and the ladder study and phase 3 ARCWay. The PDS structure is a novel drug delivery device consisting of non-biodegradable, refillable implant that provides a continuous releasing of ranibizumab into the vitreous for about 6 months. The device is approximately the size of a grain. It has 2 proximal end and distal end. The proximal end we inject the drug, and the distal end releases the drug through a semi-permeable titanium membrane by diffusion. This is the port delivery system. The 4 pictures. The third picture is the slit lamp appearance, and this is the port device. So what are the complications? The main complication in this port delivery system was vitreous hemorrhage. In the first study clinical trial, it was about 50%. Other complications: conjunctival bleb, filtering leak, vitreous hemorrhage, as I said, cataract, conjunctival erosion, retraction, endophthalmitis, and rhegmatogenous retinal detachment. This is the Susvimo. Sorry. This is how it's done.
Delivery system. And Susvimo is surgically implanted in.
It's an operation, and I think it's not an easy one, in which we do conjunctival incision and releasing the tenon and making a flap, scleral flap, as we see like this, and putting the Sosvimo PDS at this place. Of course, there is many complications for this procedure, like irritation, like migration, and of course endophthalmitis. The incidence of endophthalmitis is not as high as was expected by far from the first clinical trial, but the vitreous hemorrhage was a main problem in the complications, which they decrease this complication with the further trials. As we see, fashioning flap, scleral flap, and doing laser at it, and opening the choroid, and putting the PDS. Talking about the corticosteroid, Ozurdex, which is the most famous nowadays, the recommended dose is 1 implant administered intravitreally in the affected eye. It stays about 3 to 4 months. The company says about 6 months, but actually it's about 3 months in practice. Rationale, it's potent, targeting underlying inflammation, water-soluble, preservative-free formulation, inhibit edema and fiber deposition. Dexamethasone has benefits over other corticosteroids, yes, has lower in vitro ocular toxicity versus triamcinolone and fluocinolone acetonide. It benefits sustained release and targeted delivery. And as I said in the first slide, this is the main benefits of the drug delivery system. Increased IOP is a non-adverse effect. The mean change from the baseline increased following each injection of Ozurdex and peaked at a similar level post-injection. It returns about the 6 month post-injection. Approximately 1/3 of patients experience a clinically significant increase. The incidence of magnitude of the IOP elevation didn't increase over time with injection. There is no accumulative effect. Surgical management of cataract, incidence of cataract here is about 67%, and 60% had done cataract extraction. While Iluvin, which I'm going to talk about, it's about 87.2%. Iluvin is a novel drug. It's a continuous micro-dosing system. It's like
Iluvian's applicator has a 25-gauge needle.
4 millimeter.
This produces a self-sealing wound, so there is no need for a tunneling procedure.
As we see, and this is how does it work. This pellet slowly releases the drug. Sustained in vitro delivery, it works for about 36 months, 3 years. The sustained release implant is an approved recommended treatment modality for diabetic macular edema, with implant provides a stable and sustained visual gain over a period of 36 months. An indication of UGE's diabetic macular edema, and the clinical efficacy of Iluvin was evaluated in the FAME study at 24 months. The mean change was about plus 4 ATDRS lines, and at 36 months, the visual improvement effect was sustained with 33%, achieving 15 letters.
الهوم-made message.
الهوم-made message, it's important and safety technique. The only problem in Iluvin is the high rate of cataract in the patients.
مش حاجة بطيئة، ده 72%.
Thank you very much. 82 to 87%.
شكرا يا محمد. شكرا جزيلا. محمد المصري هيكلمنا عن توك كويس قوي مهم، systemic treatment for diabetic macular edema. ده اعتقد ان دي توك هيبقى مهم قوي. متوقعين يا محمد انه توك مهم، خلي بالك.
ان شاء الله باذن الله. طبعا مساء الخير، وانا سعيد بوجودي النهارده، وممكن بس اعمل برزنترز فيو بس الاول، معلش ولا صعب؟ اعمل لا في السلايد شو.
لا انا عارف ان محمد تو ذا بوينت هيقول لنا يعني.
محمد المصري
تمام. فانا I'm والله greatly honored ان انا اقف النهارده. طبعا ثانك يو دكتور احمد عبد الهادي ودكتور مجدي.
مش تسمعه بس.
حاضر.
ما تستناش انك تخلص، الناس عايزه تستناك تخلص، لا.
من عينيا الاثنين. من عينيا الاثنين. نظبط بس حاجه في الديسبلاي لحظه واحده.
على فكره احنا كنا عايزين نتعلم. عايزين نتعلم منكم، بس يعني الوقت
كمان كميه المعلومات والتحدث بشكل مش.
لا مش ميرور. مش عايزهم ميرور. شكرا. ثانية واحدة. Thank you so much. كده جميل. كده. المفروض ان هي دي تيجي مكان دي بس. نعم. مش عايز اهو وصل اهو الحمد لله وصل. بس الماوس جالي، الماوس كان بره وجالي. بس كده جميل. شاكرين جدا. تمام. وصل فين؟
كده الكاميرا عشان
بس كده. اوكي شكرا. احنا كده تمام. متاسفين على العطله البسيطه دي. Thank you so much. فالسيستميك management of diabetic retinopathy is very important, and just like Dr. Ahmed Yunus has elegantly demonstrated the 50% of the picture or of the factors that the patient has no control on, which is the genotype and the phenotype. I'm going now to quickly demonstrate that the 50% that the patient may control. So the degree of glycemia is number one. To cut it short, a very famous trial, which is the DCCT, the Diabetes Control and Complications Trial. And this trial has demonstrated the effect of intensive treatment, of intensive control of diabetes on the development and progression of diabetic retinopathy in insulin-dependent or type 1 diabetes mellitus. So the methodology was that it is a prospective study, and the intensive insulin therapy arm was controlled and was compared to the conventional therapy over a period of 6.5 years in type 1 diabetics. And these patients, they were furtherly divided into two cohorts. The first one was patients with no diabetic retinopathy, and the second cohort with patients with mild diabetic retinopathy. And then they monitored the progression of the retinopathy. The intensive therapy, and this is an important slide, that the fasting blood glucose is between 70 to 120 milligram per deciliter. And the postprandial blood glucose doesn't pass 180 milligram per deciliter, and the hemoglobin A1C was controlled to below less than 6.5 or 6.05%. Well, the results that actually everything was logical, that the first appearance of diabetic retinopathy incidence was decreased for over 4 years. Diabetic retinopathy appearance decreased by 76% in patients with no diabetic retinopathy. The patients with mild non-proliferative had a decreased risk of development to proliferative or non-proliferative or severe non-proliferative diabetic retinopathy by 47%, and the need for laser photocoagulation decreased by 51%. And also albuminuria and nephropathy incidence decreased. But the problem is that there was a serious adverse effect with some patients, which is severe hypoglycemia. The ADEX study, which is the epidemiology of diabetes intervention and complication study, demonstrated that, and it was, by the way, it's an extension of the DCCT. It demonstrated the same effects, the beneficial effects, that persisted for additional 4 to 10 years, and more recently, up to 23 years. So these effects, actually, they are long-term effects for glycemic control in diabetics, either to prevent the appearance of diabetic retinopathy or to prevent the progression of mild diabetic retinopathy to more severe forms. The relative risk also was around 50%, as we see. Another study, which is the United Kingdom prospective diabetes study, and it was actually in 1998. They compared intensive blood glucose control with the conventional treatment in type 2 diabetics. The first one was in type 1 diabetics. And they found that every 1% decrease in the hemoglobin A1C is associated with a 35% decrease in the risk of microvascular complication. Every decrease in the hemoglobin A1C is associated with a decrease 35% risk in the microvascular complications. Also, Protocol T demonstrated that there is a huge correlation of visual acuity improvement in patients receiving anti-VEGF with lower hemoglobin A1C level, just like Dr. Osama has beautifully demonstrated right now. But beware that rapid tightening of glucose has some disadvantages, and there are papers that demonstrate that there is early worsening of diabetic retinopathy with fast control, and I will not go deep in this area. Dr. Muhammad Olah will demonstrate this in the next talk, inshallah. And now we have finished the part which is connected to the glycemia, and now going to talk about the blood pressure. The UK PDS also demonstrated that blood pressure control has an association with micro and macrovascular complications of diabetes mellitus. It actually had a bit cohort of patients, but they have a high baseline. They had a high baseline systolic blood pressure, which is 150/100 from the start. And this study beautifully demonstrated that every 10 millimeter mercury decrease in the mean systolic blood pressure decreased diabetic retinopathy by around 13%, which is very significant. On the other hand, the ACCORD study, which is, tight blood pressure control decreased the need for retinal photocoagulation by 35%. On the other hand, the ACCORD study, which is the Actions to Control Cardiovascular Risk in Diabetes study, they studied the glycemia and the blood pressure and blood lipid control and examined the effect of adding fenofibrate on the progression of diabetic retinopathy. And they found that intensive glycemic control, of course, and lipid control, which is a very important part, decreased the progression of the retinopathy by 30%. Use of fibrates which lower the triglyceride, they decreased the incidence of retinopathy, but this effect did not persist in the 8 years data. And the intensive pressure control in the ACCORD study did not demonstrate a significant effect, but the difference here that most patients in the ACCORD study were normotensive from the start, not with a high baseline systolic blood pressure as demonstrated in the UK PDS study. Considering nephropathy, there is an association between the nephropathy and microbinuria and gross proteinuria. And of course, the gross proteinuria is a risk indicator for proliferative diabetic retinopathy in type 1 diabetics. And, but no clinical data trial denote that the interventions or preventing or slowing down diabetic retinopathy or nephropathy will reduce the incidence and progression of retinopathy. There are other miscellaneous factors that certain types of exercise can aggravate vitreous hemorrhage in PDR. Pregnancy, as Dr. Tamer elegantly demonstrated, the diabetic retinopathy should be monitored closely. Sildenafil should be asked upon in history because they increase the incidence of vitreous hemorrhage in proliferative diabetic retinopathy. Anticoagulation is not contraindicated in diabetic retinopathy. Anemia can result in progression of diabetic retinopathy, and smoking, of course, should be discouraged. Also, diabetic patients may benefit from dietary modifications. The PREDIMED study and the DIFUS study, which is diabetic visual function dietary supplement study. These studies were in 2016, and they found that diabetics can benefit from polyunsaturated fatty acids and certain dietary modifications. And the ultimate cure, of course, is either stem cell transplantation for curing diabetes or artificial pancreas. And this would be the ultimate cure, inshallah. Thank you so much.
محمد انت ما كلمتناش على نقص عمليات تغيير المسار في المعده خالص.
الباي باس؟ صح، مهمه
في المعده.
هي الباي باس بتكنترول الجلايسيميا البايباس او طبعا يعني السليفز they are a part of controlling glycemia and blood pressure.
انت هتتكلم في دي انا عايز
as if يعني if it's a part of controlling glycemia and blood pressure فطبعا طبعا
هو اكشلي هم لقوا ان البارياتريك سيرجري في العيانين اللي البيزل ميتابوليك ريت بتاعهم اكتر من 31 بيحصل لهم resolution of the diabetes, resolution of the hypertension. وبعدين فوجئوا ان الميني باي باس في العيانين اللي اقل من 31 بودي ماس اندكس بتاعهم وراحوا جايين مغيرين اسمها ومسمينها ميتابوليك سيرجري، يعني it is not diuretic anymore. ولقوا ان وانس ان انت بتعمل شيفت من الاستومك للجوجنم الجلوكاجون 1 بيخش ياكت محل الانسولين في 97% امبروفمنت في الدايابيتس ريزوليوشن، 95% ريزوليوشن في الهايبرتنشن.
لانك انت اضفت اضافه جميله جدا. شكرا يا محمد حقيقة.
شكرا ميرسي.
لولا كلام عمرو يعني كان الموضوع يبقى ناقص بالنسبه لك. كده تمام.
جدا. شكرا ميرسي. شكرا.
دكتور امير رمضان.
هنسمع بقى كلام جميل ان
أمير
شاء الله.
رمضان. هنسمع بقى الليزر بقى مش كده؟
هنسمع كلام علمي
الليزر
براكتيكال ان شاء الله الناس تستفيد منه.
تهيألي ماشيين كويس ها؟
Good evening. Thank you for allowing me to speak in this meeting. My talk is about integration of laser and pharmacotherapy in diabetic macular edema. Laser is a dying art. A lot of the young generation doesn't know how to do laser, but do we need it really or not? We will talk first about the laser. When do we apply laser? How does laser treat diabetic macular edema? Where is laser applied? How is laser applied? What are its side effects? And then laser versus pharmacotherapy. How do they manage which is have the upper hand? And lastly, new laser modalities. When do we apply laser? In cases of clinically significant macular edema, this is the classic teaching. According to the early treatment diabetic retinopathy study, it results in improvement, reduction of the moderate visual loss by 50%. But unfortunately, the visual improvement occurs only in a minority of cases. The major aim of our treatment was to stabilize the visual acuity. How does it act? In cases of focal leakage, it acts by direct occlusion of the lumen of the microaneurysms. But the role of the grid photocoagulation is not well understood. It may act by destroying the photoreceptors, decreasing the oxygen demand, increasing the oxygenation through the laser scar, stimulating the RPE cells to produce pigment epithelial derived factor, decreasing the VEGF by destroying the ischemic retina, decreasing the area of abnormal leakage by the laser scars, and also by autoregulation and decreasing the blood flow to the eye. Where is laser applied? It is applied in an area that extends from 500 micron from the center of the macula to 300 micron, and we avoid applying laser in the area of 500 micron near the disc border. How is laser applied? The old ETDRS guidelines recommended larger spot size and the spacing of one burn apart, but that was later modified by a new protocol using smaller spot up to 500 micron, shorter duration up to 50 millisecond, wider spacing by two burn apart, and lowering the power. For focal treatment, we aim for a mild gray burn of the microaneurysms and not whitening of the microaneurysms. And for grid laser, we apply laser to the area of diffuse leakage and non-perfusion with barely visible laser burn. And laser can be repeated in 3 to 4 months interval. What are the laser side effects? Laser can result in permanent damage of the photoreceptors and the RPE. Paracental scotoma, especially if the treatment is have high power and large size, and it may also encroach on the fovea. And if there is intense treatment, there may be decrease in the color, vision, and the contrast sensitivity. And if there is high power with a small spot, there may be rupture of the RPE with development of a CNV and deciform scar, which would be a very bad outcome. So this stimulated the research for pharmacotherapy for treatment of diabetic macular edema. This is a photo showing high intensity treatment with encroaching on the fovea, and the other with new lighter treatment laser spots. So the first drug was steroids. which would improve vision more, laser monotherapy or steroid monotherapy. This was studied in Protocol B, as Dr. Osama Nagar showed, and over 12 months they compared laser photocoagulation versus 1 and 4 milligram intravitreal injection of triamcinolone, and after 2 years follow-up, the improvement of the visual acuity was modest in all groups, and there was no significant difference between them. The laser group improved only 1 line, and the triamcinolone groups decreased in the visual acuity. So triamcinolone acetinoid showed no long-term benefit in visual acuity improvement over the laser. So then there was search into the anti-VEGF, which would improve vision more, anti-VEGF monotherapy or laser monotherapy. It was found that although laser halt the disease progression, the therapy with anti-VEGF appeared to restore the vision, but this had to be proven with clinical studies. Studies were done over the 3 drugs. The bevacizumab, the Avastin, was studied in the BOLT study, which compared bevacizumab injection at 6 weeks interval versus laser at 4 months interval. And after 12 months of follow-up, the group of Avastin injection improved 8 letters, while the group of laser injection lost half a letter. This photo shows the first year result. The group of the bevacizumab is improving in vision, while the group of laser is showing visual diminution. And this the 2 years result. We see that the bevacizumab group still improving in vision, and the laser start to catch up. The vision start to improve, but didn't reach the visual improvement found with the bevacizumab injection. This was also studied for the aflipercept in the Da Vinci study, which compared 4 regimens of treating with aflipercept versus laser. And after 1 year of follow-up, the groups of aflipercept improved from 8 to 11 letters, while the laser continued to lose vision. This was also found and seen in the VIVID and VISTA study, which was a longer study, and the group of laser improved 0.7 to 0.8 letters, while the aflipercept groups improved 11 letters. This was also seen with the ranibizumab in the right study, in which ranibizumab was injected monthly, and still there was marked difference in the visual improvement for laser versus the anti-VEGF. So the conclusion from these studies that since the development of anti-VEGF, better visual acuity results were obtained and greater decrease in the macular thickness when anti-VEGF drugs were used alone when compared with laser monotherapy. So currently the approved ranibizumab and aflipercept and the bevacizumab have become the first-line treatment for centrally involved diabetic macular edema. The next question. Does adding laser to anti-VEGF results in more visual gain? So we okay that anti-VEGF are better. If we add laser, we have better vision or not? A couple of studies try to test this. This is the READ-2 study. They had 3 groups: ranibizumab alone, laser alone, and ranibizumab together with laser. The first 2 lines show that there was no significant difference in the final visual outcome when we added laser. And the laser group is the one below. It didn't improve except after 6 months when we started to add ranibizumab to the treatment. The only difference was that there were fewer injections with initial laser treatment. Treatment was given in the beginning of the trial and at 3 months if needed. This was also shown in the RESTORE study, which was dependent on a PRN strategy. Ranibizumab was given monthly for the first 3 months, then PRN, and laser at baseline, then PRN. Still, there was no different and no benefit by adding laser except fewer injections. Also, a similar study like the RESTORE study is called the REVEAL study. It was done in the Asian population and showed the same results. Another study is called the RETAIN study. It tried to test the treat and extend. Is it so it excluded laser. Laser is bad. So is the treat and extend has the same effect and benefit as PRN? So they tried PRN versus treat and extend versus treat and extend and laser, and they found actually that treat and extend had a weaker effect in improving the vision than the PRN and the PRN laser. So this would tell us that if we plan to treat patients with treat and extend, it would be useful that we add laser together with it. And one of the most important study was the Protocol I, and it added another thing. It didn't compare anti-VEGF and anti-VEGF with laser. It compared anti-VEGF with prompt laser and anti-VEGF with different laser. So it entered the laser at the end of the study, and it found that still the visual improvement was comparable, but the group that had different laser had a better early improvement of vision. After 5 years, the visual improvement was comparable. So in the ranibizumab treated eye, the timing of the laser appeared to have no real impact on the visual and the anatomical benefit achieved in these patients at 1 year. And the deferred laser group was associated with a superior visual acuity area and a greater proportion of eyes experiencing more than 15 letters gain. So this tells us that we do not have to start by laser and we can postpone it. Another question, could laser be added as a rescue treatment for persistent diabetic macular edema? This actually was done in the RIDE and RISE study. 39% of the patients had laser treatment, which was started after the 3rd month of the treatment, and also in the Protocol T study, in which the laser treatment was given, but it was postponed after 6 months of the treatment if there is persistent macular edema, and it was given in about from 40 to 60% of the cases according to the drug. So macular therapy can still be used as an adjuvant. Macular laser therapy can still be used as an adjuvant treatment because of its synergistic effect with the anti-VEGF. But routine combining of laser treatment with anti-VEGF is not warranted for center involving diabetic macular edema. Occasionally, adjuvant delayed laser can be considered when there is leaking microaneurysms away from the fovea that persist despite regular anti-VEGF treatment. So it can be given, but after we finish our trial with the anti-VEGF. Another question.
لا انا بقول هي دي الكونكلوجن اللي فات. السلايد اللي فات كويس قوي خلاص. لا كمل اصل.
Another question. There are certain special conditions. How to treat clinically significant macular edema without center involvement? In a lot of our cases, when we treat the macular edema, there's a residual edema away from the fovea. How do we treat it? Well, it can be one of 3 conditions. Either there is focal leakage that is near the fovea within 500 micron of the phase, or focal leakage away more than 500 micron from the phase, or diffuse leakage. In the 3 conditions, I can observe and wait till it involves the fovea, and then I treat. And there is another option in each case. If there is if it is far from the fovea, I can do focal laser photocoagulation. So that's why it's not wrong that we learn how to do laser. We can use it in this condition. If it is non-centered involving more than 500 micron from the foveal center. If it is very near to the foveal center, we can watch, or we can start by pharmacological therapy, but there is some logistic difficulties in certain areas because the edema sometimes it is below 400 micron, and you cannot, if there is insurance, you can't offer treatment. And if it is diffuse leakage, we can do modified grid treatment or watch. Another question, how to treat eyes with center involved diabetic macular edema with good vision, more than 6/9. All the studies were done in patients with vision less than 6/9. We have 3 options according to Protocol V. Either we can observe till the vision diminishes or the edema increase. We can do still conventional laser, and we can do sub-threshold laser treatment.
أمير احنا يعني انت يعني قلت شوية سلايدز جميلة جدا 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 حقيقة يعني.
أشكرك عليها جدا.
متشكرين جدا يا دكتور أمير حقيقة يعني.
كده تتعلم كل ده. كده انت
دكتور محمد لولح.
دكتور محمد لولح.
هيكلمنا.
اتفضل دكتور محمد لولح.
تماما proliferative diabetic retinopathy.
proliferative diabetic retinopathy.
ده بقى ايه يعني.
ده ليزر بقى.
ده مش ليزر خالص بقى.
ايه؟
ده يعمل PRP بس.
proliferative diabetic.
طبعا.
هو ده الكلام
هو الكلام الصح بقى. والله هو محمد
معلومات كتيرة نفسنا نعرفها ونتعلمها.
محمد المصري هيخليك تعمل PRP بكميات رهيبة بعد كده.
والله
لأن لما تطلع الدراسة بتاعت البريفري أوف ذا ريتنا حقيقي هتلاقي الناس فوق 5 سنين دايابيتس كلهم محتاجين ليزر.
بص أنا حالات الليزر بتاعتي اللي عاملها من 10 سنين و15 سنة.
مش بتندم عليه.
من مطروح
مش بتندم على حاجة فيه.
أقول له أنت ما جيتش ليه؟ يقول لي حاجه ليه؟ انا كويس. عامل لي فلوريسين.
بتقول يا طيب بس. الحق الطاقه.
طب يلا. عطلناك شويه؟ طب يلا.
يلا يا محمد.
بعد كده اخر
Bismillah ar-Rahman ar-Rahim. I would like to talk about the BDR treatment. Firstly, we must know the natural course of BDR, MVEs, MVDs, vitreous and fibrous proliferation, tractional retinal detachment, hemorrhage, causing severe visual loss, and macular detachment, ischemia, edema, optic nerve disease, and media opacity with severe retinal ischemia. The risk factors of PDR, hemoglobin A1C at a baseline with a strong factor. 25% of type 1 and 15% of type 2 developed BDR after 15 years. So the duration, another risk factor. Strong association between the development of BDR and uncontrolled systemic disease. Elevated serum lipid association with hard exit and decreased visual acuity. Severe anemia and retinopathy may accelerate during pregnancy, renal failure, extreme illness. Hypertension was not identified as a risk factor by ETDRS. My goals is to prevent or regress the proliferation of MVEs. Second, to prevent or relieve the effect of contraction of fibrovascular proliferation. Systemic medication, oral hypoglycemic like thiazolidine dionase as a treatment of type 2 acts on expression of gene located in adipose tissue and retina. Delay the onset of BDR because of anti-angiogenic effect by BBR gamma agonist activity. Lipid-lowering ACE inhibitor drugs decrease the hard exit. Protein kinase C beta, oral hypoglycemic, regulate the intracellular protein, but no effect on progression from moderate to severe non-proliferative to more levels of BDR. Once active proliferation happen, so glycemic control alone is usually insufficient. Take care in oral hypoglycemia, drugs for glycemic control for severe non-proliferative and early proliferative reduce the risk of further progression of high-risk PDR. But monitor these cases closely after initiation of intensive insulin treatment and this consideration in very poor glycemic control for long-standing uncontrolled diabetes. This early worsening were higher in greater reduction of hemoglobin A1C. The mechanism is alteration of retinal blood flow, decreased autoregulation of the circulation, transient ischemia, and decrease in nutrient substrate. So PRP prior to treatment to protect against advancing severe retinopathy is preferable. As oral treatment is highly effective in preventing visual loss and intensive glycemic control, you should not discourage the oral treatment for fear of retinopathy progression. Consider the timing of treatment by ETDRS, which compare the early photocoagulation, deferral photocoagulation, and the other goals in this study. In the past, they said that younger patients have only MVEs appear stable. Initial period of observation is generally recommended. Close follow-up may be asymptomatic and spontaneous regression, but this is before anti-VEGF. If MVE is growing, the photocoagulation usually recommended. Younger patients with early MVDs with intraretinal signs of severe non-proliferative diabetic retinopathy, prompt treatment is generally recommended. Scatter treatment should not be delayed when high-risk stage present. Entry to the high-risk stage marked by large vitreous hemorrhage. In type 1 diabetes, the MVDs, type 1, the MVDs is the first sign. In type 2, the high risk is the first sign detected by vitreous hemorrhage. This is by MVEs not observed in the on the previous visits. Thus, older type 2 diabetes with very severe non-proliferative and early proliferative suggests prompt scatter is probably safe than deferral. And DRS found the greater scatter benefit in type 2 diabetes in older versus younger patients. Please be careful about the fellow eye. if the visual function decreased in the fellow eye after scatter photocoagulation, defer the treatment may be preferable. If the first eye had an fortunate outcome without photocoagulation or with photocoagulation after BDR, so prompt treatment may be deferable, particularly if close follow-up will be difficult. As we know all about the full scatter protocol, I will stress on the burn strength. You should make a moderate intensity, depend on the clarity of the media and pigmentation of the fundus. Pan-retinal photocoagulation by DRS reduces the risk of severe visual loss, especially in PDR. Laser acts by autoregulation of the retinal circulation and oxygen diffusion over the treated area of the retina more than untreated area. So the oxygen concentration of the vitreous over the laser part is higher than the untreated. This is from severe non-proliferative to early proliferative. What about the PRP in advanced BDR? Strength should be mild to moderate. Avoid the proliferative fibrous and avoid contraction of fibers leading to displacement of detachment of the macula. If we found early neovascularization of the iris, so prompt treatment indication of the media clear, you may do PRP or anti-VEGF. Another part about the laser is Pascal, pattern scanning laser delivery system. This is shorter duration than the conventional laser, improved comfort, safety without compromising the efficacy, making uniform, predictable burn dimension with minimal thermal spread. As we know, the conventional may spread after application of the laser. Area of tissue destruction confined to outer retinal layer, less damage, less thermal effect. The regression of the BDR by regression of MVEs in days or weeks, change in the new vessels and extent of fibrous tissue. But we have many complications about BRP, the loss of vision, decrease in the visual function, field loss, damage to posterior ocular structure and choroidal effusion, maybe high intensity. Laser can make proximal membrane rupture with hemorrhage, pain, corneal erosion, mydriasis, and may do, is very rarely to do lenticular burns, progressive tractional retinal detachment, and vitreous pre-retinal subhyaloid hemorrhage. After that, the other modality of other than PRP is anti-angiogenic therapy. This is protocol S.
دكتور محمد ما شاء الله وانت اللي اعطيتنا الاوردر بقى.
انا ايه؟
كده انت الزيرو بتاعك.
انا خلاص؟
لا
لسه
in conclusion
في موداليتي سريعه بس هقولها.
in conclusion بس.
بسرعه. الانتي فيجاف in protocol S describe ranibizumab again versus PRP over the course of 2 years without baseline DME received median 10 injections, without baseline DME received median 14 injections.
عشان الدكتور احمد عبد الهادي الدور عليه وهناخد من وقته.
لا
هناخد من وقتك احنا
There are many indications for vitrectomy in BDR, like visualization of the retina, relief traction, and control progressive contraction. The vitrectomy group.
هو اللي انت قلته كفايه جدا يا محمد قوي يعني.
Eyes with mild vitreous hemorrhage with well lasered retina would not eligible for vitrectomy thanks to potential spontaneous resorption of blood. Early vitrectomy is mandatory in case of vitreous hemorrhage in association with retinal detachment. Vitrectomy should also be considered in case of dense recurrent vitreous hemorrhage. Protocol AP describes the relation between early anti-VEGF and early vitrectomy for vitreous hemorrhage. Then we all want to reach this stage of quiescent stage or burned out diabetic retinopathy. Visual outcome depends on the degree of damage of visual structure. vitreous is detached, hemorrhage decrease in frequency and the severity. Thank you.
Thank you.
نشكر دكتور محمد لولح. Just a nice presentation. We're going to talk about vitrectomy and DME. I'm going to name my presentation Revisiting Vitrectomy in the Era of Pharmacotherapy as Treatment for DMO. Of course, we know that DMO is the main problem in as regards vision in diabetic retinopathy patients. Intravitreal anti-VEGF, of course, as have been said or named, is a standard of treatment since the DRCR network named them the gold standard of treatment. But in spite of this, 23% of patients still respond insufficiently to anti-VEGF. Partial plan vitrectomy is to non-responding or persistent DME is a viable treatment option. Type of DMO, like we have been shown in the previous presentations, there are tractional DME, and this before the advent of OCT, there are cases with taut adherent posterior hyaloid, and they are bimicroscopic finding in only 5% of patients. But after the advent of DME, all these cases, whether vitreofoveal traction, vitreomacular traction, or epiretinal membrane, are named tractional DME. What is the incidence of tractional DME? It is about 75% of cases in an OCT-based study. Vitreomacular traction, like in this case with constitutional changes in the fovea with epimacular traction, represent up to 25% of cases of DME. An extramacular epimacular membrane with subsequent macular striae represents 35% of cases, and up to 22.4% of cases have a real epiretinal membrane. What about the partial plan of vitrectomy in tractional DMO? Of course, it eliminates tractional element, posterior hyaloid and epiretinal membrane. And this is why is this important? Because, as we know, the presence of vitreoretinal interface might reduce the therapeutic effect of anti-VEGF. And a very important piece of information that we all face before vitrectomy, that it can shift the what we call the balance between the fibrotic and the angiogenic growth factors, what we call angiofibrotic switch, which can result in increased retinal traction in proliferative cases causing tractional DME. So vitrectomy can relieve this tractional element. What about non-tractional DMO? Of course, anti-VEGF is a standard of treatment, but we have to identify two groups of patients. Refractory patients who do not respond to any treatment administration, and in the era of anti-VEGF, these are the patients who do not respond to 3 loading doses of anti-VEGF, or they do not reduce, the thickness is not reduced to below 20% central foveal thickness, and after the results of protocol T, it is prudent to say that refractory patients are those who still have edema after 5 loading doses, especially if they were of aflibercept. What is chronic DME? It is difficult to diagnose chronic DME, but recently Bressler et al. Diagnosed them if you have a patient who has been treated with any modes of treatment and you have 2 consecutive visits where the central macular thickness is above 250 micron or the reduction is less than 10% of the central foveal thickness in 2 consecutive visits during your treatment, this is a chronic macular edema patient. Why should we identify chronic or refractory DME? Because eyes with long-standing DME will develop what we call outer retinal atrophy, like Dr. Amira beautifully demonstrated in the OCT studies. Also, the success of pharmacological treatment will cause physicians to continue treatment indefinitely. This will lead to delay in the change of treatment protocol or tactics, and this leads the patient to be offered vitrectomy very late. So, when he is offered vitrectomy, irreversible photoreceptor damage may already have occurred, and visual improvement would not be expected by any mode of treatment. Any other problems with multiple injections? Yes, despite the intensive treatment, up to 60% of patients in certain studies have recalcitrant or refractory or persistent DME after 6 consecutive injections of anti-VEGF, and this is a very large number. Also, relatively safe, but the cumulative risk of endophthalmitis after 40 injections is 1%. Also, the economic consideration, which is very important in our country. What is the pathophysiological mechanism of partial vitrectomy? We have all learned this in the early, when we were studying the effect of vitrectomy. DME improves the retinal oxygenation. It removes of the vitreous cortex in diabetic patient, which serves as a reservoir for pro-angiogenic factors and cytokines. Also, it accelerates the half-life of intravitreal cytokines, like it can accelerate the half-life of anti-VEGF after vitrectomy. Some also propose that eyes without obvious vitreomacular traction, the eye lamp may exert macular traction. So getting rid of the eye lamp may benefit, and also there is recurrent epiretinal membrane after vitrectomy with no eye lamp peeling, but this in most of the studies it was not more than 10%. What about the results of partial vitrectomy in non-tractional DMO? It is less clear nowadays whether partial vitrectomy will benefit patients. In some studies, they have said they are to do a vitrectomy study like other studies with continued anti-VEGF injection or anti-VEGF with monolaser, they both work. But other studies, on the other hand, they have no reported beneficial effect whatsoever in vitrectomy for DMO. So why is this discrepancy? Discrepancy has been due to the heterogeneity of the studies as regards the definition and the duration of recalcitrance or the refractory macular edema. The status of the eye lamp was not stated in many of the studies. Also, the follow-up period was not the same. Also, the nature of the intervention was not the same in all studies. Although these studies were based also on eyes with previous failed macular laser photocoagulation, not de novo eyes, and had persistent DME for a long time. Eyes with shorter duration may do better with partial blind vitrectomy as primary treatment, not as a salvage treatment. And this is a patient who has done only partial vitrectomy for this persistent DME, and he has improved, and the lower patient the same, but the vision is not improved whatsoever because of the external limiting membrane did not improve much. Which patients to choose? Associated with greater visual acuity if the patient has no history of prior laser, lower hemoglobin A1C, worse baseline visual acuity, epiretinal membrane removal, and also greater decrease in macular thickness after vitrectomy. If you choose patient with eye lamp peeling during surgery, presence of vitreomacular interface abnormality, which is of course relieved by the vitrectomy, worse by baseline visual acuity, and greater baseline macular thickness. Nowadays, there is the era of subretinal surgery. The idea came because the improvement of the condition related after vitrectomy takes time, and during this time, the photoreceptor cells may become permanently damaged by the chronic macular edema, leading to poor visual acuity. Furthermore, the recent OCT observation shows that the shorter duration from the onset of DME to the resolution of is a major factor affecting the integrity of the ellipsoid zone and the good visual outcome, so indicating the importance of rapid resolution of DME after vitrectomy. The idea came to Yuki Morizan et al. In 2015, planned foveal detachment for the resolution of DME, where they offered vitrectomy with subretinal BSS, which showed rapid improvement of DME, and this indicates that this novel technique improves DME pathology by a mechanism different from all other mechanisms that we have already mentioned. First, injection of BSS into the subretinal space decreases osmotic pressure and viscosity of the subretinal space, and this may promote water transport from the subretinal space to the choroid via the RPE, also establishing the resumption of the supply of nutrients and oxygen from the choroid to the retina, and this is a rapid phase. Second, injection of BSS into subretinal space improves the environment surrounding the RPE by washing out inflammatory cytokines and migratory cells, and this is a slow phase. And the third, injection of BSS into subretinal space may cause temporary halting of the external limiting membrane action, so separates the environment of the retina from the subretina and restricts water movement from the subretina to the retina that might facilitate absorption of edema from the retina, and this is both a rapid and a slow mechanism. We have taken this further to perform a study on 28 eyes, evaluating this technique in both vitrectomized and naive eyes, those with normal and those with abnormal vitreomacular interface, and also some of these eyes were treated with intravitreal triamcinolone, and both groups with previous vitrectomy or with naive eyes both improved in their visual acuity. But the cases with no previous vitrectomy improved more. Let's share some cases. This is a case with central macular thickness of 639 after 8 injections of ranibizumab and 3 injections of Avastin over 1 year. The visual acuity is 0.05. We tried 2 triamcinolone injections. The central macular thickness is still 557, and visual acuity did not improve. We offered the technique of vitrectomy, eye lamp peeling, and submacular injection of BSS to cover the entire area of the macula, and this is only it is about 232 after 4 weeks, and after 10 months it is about 235 with no injections given in the year after the surgery. and the visual acuity improved to only 0.16 because to start with, this is the case with destroyed external limiting membrane and ellipsoid zone. What about eyes with structural macular edema? Do they benefit? Also, they benefit. This is a case 2 years presented in 7/2016. Pseudophakic, 0.3 vision, have had 6 injections of bevacizumab, 2 injections of ranibizumab, and inadequate diabetic control. And after also 3 injections of ranibizumab and 2 injections of aflibercept, the patient didn't improve with the diffuse diabetic macular edema in the fluorescein. We offered the technique to the patient, which is core vitrectomy, only 1 minute. Core vitrectomy, detachment procedure followed by triamcinolone, and we washed out the triamcinolone entirely at the end of surgery. And don't remember, we included cases where there were previously triamcinolone injected, because some people might say that the triamcinolone might work in these cases. Staining with BBG under air and doing a complete ILM peeling and removal of the epimacular membrane, and then staining again. This is ILM. Previously it was epimacular membrane, then injecting subretinal BSS at different sites to cover the entire area of the macula. The fovea itself should not be injected because this patient, if it has a large cystoid space, this might create a macular hole. This patient improved 2 weeks after surgery and still 6 months he's okay. The same with previous failed vitrectomy. This is previous failed vitrectomy, injected triamcinolone, injected full doses. The patient didn't improve, and this is the patient was offered this surgery. This is only 1 month after surgery. He's 274. The visual acuity did not improve much to 0.1 because of the destroyed ellipsoid zone and external limiting membrane. 10 months later, the patient is doing fine with no injections, and I've done these eyes since 5 years, and the patient didn't receive a single injections after this. So the take-home message is to offer this surgery early for patients of refractory DME after trial of 5 or 6 injections of anti-VEGF. Shifting to other anti-VEGF should be treated, should be used, and also use of triamcinolone should be tried. But after all this have failed, partial blindness vitrectomy is a good option with subretinal BSS injection. Thank you.
شكرا يا دكتور أحمد، متشكرين جدا جدا. كل توك عايز وقته، بس احنا ما عدناش الوقت ده للاسف. متشكرين جدا، شكرا يا دكتور احمد.
خلاص. Please. ندعو the speakers please for the last session to okay. اوكي اتفضل ماشي.
مساء الخير، انا ناردين ناجي برودكت مانجر مينا فارم. في البدايه طبعا احنا سعداء جدا ان احنا مع حضراتكم في such an important scientific event. سعداء وبنشكر اساتذتنا طبعا for their presentations، وبنشكر استاذ الدكتور محمد عبد الهادي الحقيقه في الفرصه دي ان احنا نكون متواجدين مع حضراتكم النهارده. سريعا نتكلم مع حضراتكم مينا فارم الحقيقه، وبنقدم يمكن احنا مع حضراتكم من فتره كبيره جدا في الاوفثالمولوجي ماركت. يمكن مينا فارم موجوده في الايجيبشن ماركت من سنه 58، بتقدم دايما واور فيجن ان احنا نقدم للماركت دايما انوفيتيف وكمان افوردبل برودكت تناسب الايجيبشن ماركت. الحقيقه مينا فارم مش بس بتصنع الادويه بتاعتها اللي احنا بنقدمها لحضراتكم، لكن مينا فارم كمان بتصنع لشركات تانية. يعني حضراتكم ممكن تلاقوا شركات تانية زي مثلا ميرك، زي سانوفي، عليها لوجو مينا فارم كمان العلبه، وده بيكون مصنع مينا فارم. الحاجه كمان الحقيقه اللي احنا مميزه جدا في مينا فارم ان احنا واخدين لايسنس من شركات عالميه ملهاش تواجد هنا في الايجيبشن ماركت. يمكن من اشهرها مع حضراتكم بوش اند لومب طبعا بورتفوليو القطارات، وكمان سويسرا اللي بتقدم لحضراتكم الدوكسين. مينا فارم تعتبر اول شركه مصريه في مصر والميدل ايست كله يكون عندها مصنع بايو تكنولوجي راين مينا فارم، وده كان في 2001 بدا انشاؤه، وبدا تصنيع كل الادويه بالهندسه الوراثيه. من اشهرها ومن اول برودكتس اللي قدمت الانترفيرون المصري وقت فيروس سي لو حضراتكم تتذكروا. الحقيقه رايفيرون حاليا موجود برضو يمكن انديكيشنز كتيره مع حضراتكم، يمكن زي اليوفيايتس او حالات ثانيه كتير ممكن نحتاج فيها الانترفيرون الفا 2 اي، وده افيلابل بتقدمه مينا فارم. مينا فارم في 2010 استحوذت على شركه بروبايجين الالمانيه، وده كان يونيك بزنس موديل، لاول مره شركه مصريه تستحوذ على شركه اجنبيه مش العكس. فاينلي في 2021 بروبايجين مينا فارم انكوربوريتد ميجانترا، ودي متخصصه في البايوسيميلرز والفاكسين. علشان كده بنشارك مع حضراتكم اور بريكنج نيوز انه مينا فارم هي هتبتدي اوريدي في البروسيس ان احنا نصنع سبوتنيك في اللقاح الروسي. وزي ما حضراتكم عارفين اللقاح الروسي يمكن يعتبر اعلى افيكاسي 97%، وهيبتدي كمان مش بس يتقدم في الماركت لكن كمان هنبتدي نصدر سبوتنيك في لبره مصر كمان. وبنأكد انه سبوتنيك في الحقيقه مش بس تعبئه لكن تصنيع، التصنيع هيحصل في مصانع مينا فارم زي ما حضراتكم شفتوا. الحقيقه النهارده وخاصه يعني احنا بنتكلم على يوم مهم دايابيتك ريتينوباثي، بيهمنا بدايه نتذكر مع حضراتكم مشاكل الدايابيتك ريتينوباثي، هاو الدايابيتس او دايابيتك ريتينوباثي ستارتس، هاو البروجريشن ممكن يؤدي لمشاكل كتيره ممكن توصلنا للبلايندنس، وهاو ان الدوكسيوم بيجي في الوقت ده ويقدر يعمل بروتكشن اجينست فيرذر بروجريشنز. الدوكسيوم طبعا من الادويه البراند مع حضراتكم من ماركت بنتكلم عليه محلات دايابيتك ريتينوباثي اندر لايسنس شركه اوم سويسرا، موجود في اكثر من 65 دوله في العالم باسم الدوكسيوم. الحقيقه الدوكسيوم ميزته هنا ان هو حضراتكم عارفين ان هو بيشتغل على ان هو بيحسن الريتينال بلاد فلو، كمان ليه دور ان هو يقلل الفي جي اف. اتس نوت ان انتي في جي اف لكن ليه دور ان هو يقلل اكسبريشن اوف في جي اف. عشان كده بنتكلم قد ايه فعلا الدوكسيوم بيقدر يحمي البيشنتس بتوع حضراتكم against further progression of diabetic retinopathy. النهارده يهمنا يمكن اكتر ان احنا نتكلم على اور نيولي لانش برودكت النت اوف تيول والنت اوف تيول بلس انتي اوكيولر انتي انفكتيف. الحقيقه الناتلمايسين ودي الماده الفعاله اللي في النت اوف تيول هي اول مره يتعمل لها انترودكشن في الايجيبشن ماركت. هي يمكن موجوده في يوروب من اكتر من 10 سنين، لكن في مصر هنا اول مره بنقدم لحضراتكم ماده الناتلمايسين، قدمناها في نت اوف تيول وهي تعتبر في جروب الامينوجلايكوزايدز لكن بتتميز عنه في حاجات كتيره هنقولها لحضراتكم. وكمان بنقدم النت اوف تيول بلس، وطبعا فور اوكيولار انفلاميشن كمان معاه الناتلمايسين ومعاه الدكساميثازون. زي ما حضراتكم عارفين اغلب الباثوجين او ذا موست كومن هم ستافيلوكوكس اوريوس سودوموناس اريجونوزا. طب هل النت اوف تيول او ناتلمايسين ليه تاثير عليهم؟ دي فعلا ايوه، انه كانت ايزوليت معموله في عدد كبير من الدول 767 بكتيريال ايزوليت، لقينا ان الستافيلوكوكس اوريوس 100% سسبتبل للنت اوف تيول، والسودوموناس اريجونوزا كمان 100% سسبتبل للنت اوف تيول او نت اوف تيول بلس. الحقيقه كمان الكيموثيرابي اهتمت ان هي تقارن هل ناتلمايسين فيرسس الاذر امينوجلايكوزايدز، وقارنت كمان الناتلمايسين او النت اوف تيول فيرسس الفلوروكينولونز، وهو دول اكثر جروبس مشهوره طبعا في الماركت كانتي انفكتيف. بالنسبه للاذر امينوجلايكوزايدز لقوا انه الناتلمايسين او النت اوف تيول شو مور ذان 90% سسبتابيلتي، شو كمان سسبتابيلتي اجينست ريزيستنت سترينز للتوبرامايسين والجنتامايسين، وكمان النت اوف تيول ليه بكتيريسايدال اكتيفيتي within 1 hour. طب وات اباوت الكينولونز او الفلوروكينولونز؟ الكيموثيرابي قالت انه النت اوف تيول شود longer post antibiotic effect compared للكينولونز. مش بس كده، الحقيقه كمان كورنيا اهتمت ان هي تقارن السبيكترم اوف الناتلمايسين او النت اوف تيول فيرسس الفلوروكينولونز، المعروف طبعا البرود سبيكترم بتاعها. حضراتكم هتلاحظوا ان النسبه متقاربه الى حد كبير، الناتلمايسين 94% فيرسس 96 فيرسس 97، فيعني تعتبر كومباربل جدا. فكانت كلمت الكورنيا وقالت ان النت اوف تيول او كلمت عن الناتلمايسين provided a broad spectrum coverage comparable للفلوروكينولونز. فاينل الكلينيكال ترايل دي اتنشرت في الكلينيكال اوفثالمولوجي 2020، كانت بتقارن الدكساميثازون ناتلمايسين فيرسس الدكساميثازون توبرامايسين، وبداوا يشوفوا لقوا انه البيشنتس دول في خلال يعني فتره الترايل شود بيتر او اعلى ريزوليوشن للباربر كونجكتيفال هايبريميا. مش بس كده، لكن كمان قاسوا السبجكتيف ميجرز بتاعت البيشنت، لقوا فيرسس ريجاردنج بلورد فيجن الفورين بوديز البيرنينج وكل الحاجات دي البيشنت اتحسن كتير مع الجروب اللي استخدم الناتلمايسين او النت اوف تيول. هنا بنتكلم عن نت اوف تيول بلس بما اننا بنتكلم على كومباينيشن. فاينلي بنأكد مع حضراتكم ان النت اوف تيول بلس اول ناتلمايسين يتوفر في الايجيبشن ماركت، وبالتالي ريزيستنس اتس نو مور كونسيرن. طبعا المشكله الكبيره دايما يمكن الابيوز اوف انتي بايوتكس في العموم ومشاكل الريزيستنس كتيره بتظهر، المريض خلاص في بعض الحاجات حفظها بتحصل مشاكل دي كتير. فاحنا هنا عندنا بنقدم لحضراتكم برودكت مش هيبقى ريزيستنس كونسيرن اني مور الفتره الجايه بوجود النت اوف تيول ونت اوف تيول بلس. زي ما قلنا لحضراتكم ريجاردنج لو هقارنه بالاذر امينوجلايكوزايدز هنلاقي انه انا الريزيستنس بتاعتي او السسبتابيلتي بتاعتي اعلى بكتير، وكمان لو هقارنه بالفلوروكينولونز فانا في السبيكترم انا متقارب جدا من الفلوروكينولونز. فده بالنسبه للنت اوف تيول ونت اوف تيول بلس. اسمحوا لي بس اخيرا اذكر كمان بالاوفتاتروف حالات الجلوكوما. الاوفتاتروف الحقيقه مينا فارم برضو لما فكرت تقدم ميديكيشن فور تريتمنت اوف جلوكوما اهتمت جدا ان هي تقدم احدث الجروبس الموجوده وهي البروستاجلاندين انالوجز، فقدمنا لحضراتكم الاوفتاتروف ترافوبروست والاوفتاتروف بلس ترافوبروست مع التيمولول. ايه اللي بيميز الحقيقه الاوفتاتروف والاوفتاتروف بلس اكوردنج للامريكان جايد لاينز واليوروبيان جايد لاينز؟ حضراتكم عارفين انه مريض الجلوكوما ده مريض كرونيك ميديكيشن هيستخدمه فترات طويله، فكان في حاجات كتيره مهمه. من اهم الحاجات انه يقدر يعمل اي بي ريدكشن بشكل كويس، وزي ما حضراتكم عارفين البروستاجلاندين انالوجز ومنها الترافوبروست وبالتالي الاوفتاتروف بيديني اعلى اي بي ريدكشن. النقطة الثانية انه وانس ديلي ابلكيشن على عكس الحاجات الجروبس الثانية البيتا بلوكرز الكربونيك انهيدريز الحاجات الثانية بتتاخد 2 أو 3 مرات، لكن هنا الاوفتاتروف اتس وانس ديلي انديكيشن. وكمان بالنسبة للسعر برضو يعتبر السعر افوردبل، الاوفتاتروف ب 60 جنيه الاوفتاتروف بلس ب 72، فبرضو السعر افوردبل جدا للبيشنتس بتوع حضراتكم. فنتمنى برضو يعني البورتفوليو بتاعنا كامل بنقدمه لحضراتكم بالاضافه للحاجات القديمه الارتيلاك والكورنيال جيل زي ما حضراتكم تتذكروا، يمكن كانت دي بدايه شغلنا في ماركت مع حضراتكم في الاوفثالمولوجي، لكن كمان حاليا احنا بناخد خطوات ثانيه ان احنا نقدم دايما ادويه جديده. يمكن السنه اللي فاتت بس زي ما قدمنا لحضراتكم النت اوف تيول والاوفتاتروف، بس دول حاليا نيولي لانشد ولسه كمان في البايب لاين في حاجات كتيره ان شاء الله هتتقدم، بالاضافه طبعا للدوكسيام البراند بتاعنا حالات الدايابيتك ريتينوباثي. بشكر حضراتكم جدا مره ثانيه، ويعني مسعداء جدا ان احنا كنا معاكم النهارده. ميرسي، شكرا.
ممكن تجيبي لي بريزنتر فيه ده تمام. بسم الله الرحمن الرحيم. بشكركم جميعا على الحضور وبشكر السبيكرز على الفاليبل برزنتيشنز، والحقيقه ما بجاوبهمش يعني كل البرزنتيشنز كانت كويسه جدا وفاليبل. وهنبتدي البانل ديسكشن دي على الكرنت كونسبتس ان مانجمنت اوف دايابيتك ماكلر ايديما، وانا برحب بكل البانلست الدكتور محسن ابو شوشه، الدكتور وليد شتا، الاستاذ الدكتور علاء فاضل، الدكتور احمد سوكا، الدكتور طارق حميده، والدكتور عمرو بسه. وبرجوهم جميعا ان الديسكشنز بتاعتنا تبقى كلير، مسجز واضحه للناس what they are doing actually in the cases. وعشان احنا وقتنا ضيق يا ريت بلاش نتكلم كتير على الساينتفك جراوندز فور ذا ديسيجنز، عايزين الديسيجن اللي انتوا بتعملوه مباشره في الحالات. اول case about a 52 years old male, type 2 diabetes, visual acuity 6/6. This is the fundus photograph of the patient, and this is the OCT of the patient. The OCT demonstrates a center involving diabetic macular edema. دكتور محسن، عيان ده جاي لك أول مرة عنده المنظر ده visual acuity 6/6 center involving diabetic macular edema. Is it important to do fluorescein angiography in this patient in your practice?
Yes, it's important.
It is important. Dr. Walid?
Yes.
Everybody agrees that fluorescein angiography should be done in these cases? Everybody agrees. دكتور أحمد سوكا بيقول نص نص، اشرح لنا ليه يا أحمد نص نص؟
أنا I'm not an advocate إن كل الناس تعمل فلوريسين، بس it's definitely a better way to screen and detect all changes. بس بجود clinical examination if I don't have any suspicious signs I don't do fluorescein.
You don't do fluorescein angiography.
As a regular thing لا.
أنا يعني هوضح الرأي الدكتور أحمد سوكا كده، يعني with the advent of anti-VEGF therapy with the corresponding decrease in the need for laser, questions arise on the need for the conventional fluorescein angiography. Currently, there is a moderate consensus on the role of fluorescein angiography in the management of diabetic macular edema. Some clinicians would base treatment decisions on the basis of OCT only. يعني في 2017 الامريكان سوسايتي اوف ريتنا سبيشالستس عملت سيرفي وسط الحضور، 50% من الناس قالوا ان هم they would order fluorescein angiography in the first visit for diagnosis of diabetic macular edema، و50% قالوا لا احنا مش محتاجين، احنا هنعمل في الحالات دي OCT بس and this is enough. دكتور طارق، ايه رايك في قرار ده طارق حميده؟
انا بطلب فلوريسين انجيوجرام for both.
You order.
proliferative changes and for diabetic macular edema, because I'm still doing focal laser for such patients.
تمام.
If I feel that there is some leaky points, I would depend
تمام.
on fluorescein angiogram.
دكتور عمرو بس بتطلب في اول برزنتيشن للعيان عنده diabetic macular edema fluorescein angiography.
Yes, I do, and I order ultra wide field fluorescein or wide field to just examine the periphery to check the macula for the presence or absence of ischemia.
اغلبيه البانلز بتوعنا اللي هم بيشتغلوا في الفيلد ده كتير بيبريفير تو دو fluorescein angiography at least in the first presentation. احنا عارفين كلنا فوائد الفلوروسين angiography in detecting the areas of vascular non-perfusion and in demonstrating the treatable lesions اللي احنا ممكن نعمل لها ليزر زي ما الدكتور طارق اللي هو لسه بيعمل ليزر sometimes for patients having diabetic macular edema. تاني سؤال بعد المحاضرات القيمة اللي احنا سمعناها عن الاوستي انجيوجرافي وكده، مين من البانلز would order OCT angiography for this case اللي احنا عرضناها اول ما جت؟ دكتور محسن؟
No.
He wouldn't order. وليد؟
No.
دكتور علاء؟
No.
احمد؟ Everybody agrees no OCT angiography in the beginning. فبرغم الفاليوز اللي الاو سي تي انجيوجرافي الناس بتتكلم عنها وان هو كان define different layers of capillary plexus وبالذات الاوتر layers, most of the retina specialists do not agree on using it as a primary modality في الدايجنوزس بتاعة الدايابيتك ريتينوباثي. هرجع للعيان ده دكتور محسن، العيان ده نظره 6/6 وعنده سنتر انفولد دايابيتك ماكلر ايديما، تنصح العيان ده يعمل ايه يا محسن؟
For me, it's for follow-up.
For follow-up.
I prefer to follow protocol.
Follow-up. وليد.
Follow-up and systemic control.
Systemic control. دكتور علاء.
برضو we have to look at the other eye. Yes. What is the condition of the other eye?
The other eye is free يا دكتور.
Other eye is totally free.
Yes.
I can put him under follow-up for 1 month and see what's going on. If it's increasing, I have to interfere.
Follow-up on short basis. دكتور طارق، ما هخليك يا احمد انت في الاخر. دكتور طارق.
I would follow up such a patient.
You will follow up. عمرو.
By protocol V I will follow up this patient.
Follow up.
According to protocol.
طيب احمد قول لي رايك.
I beg to differ. Protocol V mentioned the results of the 3 ways to do this. I do follow it. يعني I put symptomatic patients who are not happy with this vision in their work in the injection group and I explain.
خلينا واضحين يا احمد، العيان ده هابي ونظره 6/6.
جميل. I explain protocol V. I follow up 2 monthly visual acuity only visits. When the vision drops, we do the OCT and we go for the injection.
طيب يعني نتفق كده من كلام الجميع ان this patient should be followed up. وهم الدكتور احمد سوكا اتكلم على البروتوكول فيه، انا هشرح لكم ببساطه كده what is the best therapeutic strategy for eyes with center involved diabetic macular edema and good vision. الناس اللي نظرهم كويس وعندهم سنتر انفولد diabetic macular edema نعمل لهم ايه؟ البروتوكول فيه حط العيانين دول في 3 جروبس. جروب ابتدت تاخد initial management with aflibercept، جروب عملت macular laser treatment، وجروب اتحطت on observation. والثلاثه وطبعا اوبزرفيشن بروفايدد ان لو العيان حصل نظره قل هياخد افليبرسبت تريتمنت. والمين فيجن في المجموعات الثلاثه بعد سنتين كانوا 20 والافريج ريت of 5 or more letters visual loss was the same in the 3 groups. طيب احنا متفقين على الاوبزرفيشن حياتي. دكتور علاء فاضل ده فلوريسين انجيوجرام بتاع عيان دايابيتك جاي يشتكي من بليرنج اوف فيجن. لو تقرا لنا الفلوسين انجيوجرام ده هتقول العيان ده عنده ايه؟
باين طبعا في البريفري في areas of capillary drop out وفي ممكن تكون ايرماز اللي موجوده superior temporal.
ايوه.
برضه في ليت ليكج في الماكلر اريا. يعني ده عيان كده داخل على severe non-proliferative مع focal leakage maculopathy.
تمام. يعني العيان ده can we consider the lesions along the upper temporal vascular arteries new vessels elsewhere يا دكتور علاء؟
يعني I need يعني more clear picture. It can be in VEs. It can be in VEs.
can be in VEs. طيب لو اسال الدكتور محسن جالك العيان ده بالصوره دي ماكلر ايديما with probably new vessels elsewhere. ايه الثيرابيوتيك استراتيجي تنصح العيان ده يعمل ايه؟
First, I will ask for OCT.
This is the OCT of the patient.
I think first I'm going to systemically control this patient and monthly injection of anti-VEGF.
Monthly VEGF. تمام. And the monthly injection will help to control the proliferative stage and the macular edema at the same time. طيب دكتور وليد.
Monthly injection وممكن أعد after 3 injection ممكن أعمل PRP.
ممكن تعمل PRP. تمام. دكتور علاء.
Of course, we start with the monthly injection, and I think PRP is going to be needed.
PRP, monthly injections and PRP.
We evaluate the case after 3 injections.
تمام. أحمد سوكن.
We treat the macular edema starting with the monthly injections and later on as it responds, and I put the PRP whenever I will stop injections.
Okay, تمام. So it's anti-VEGF injections for macular edema plus laser penretinal photocoagulation. طيب التايمينج بتاع الليزر penretinal photocoagulation احمد قال رايه بعد ما يخلص الانتي VEGF injections for macular edema تعمل ليزر PRP. دكتور طارق.
I would, if the patient is type 1 diabetes, I will start with the injection.
هو type 2 diabetes.
If he's type 2, I will go for injection, and after the first injection, I will start immediately PRP laser treatment. I will not wait for 3 injections.
After the first injection?
Yes.
Immediately. عمرو.
I will go for deferred laser. I will inject the patient and defer the laser till 24.
Deferred laser PRP, you mean?
Yes. Or you can either use the PRP or you can either use focal, ودي based على الديف study. And no, there is no difference يعني بين الاثنين. But I will go for PRP after finishing the anti-VEGF injection.
After finishing the anti-VEGF injection. طيب. العيان ده رجع بعد 5 شهور بعد ما خد 5 anti-VEGF injections. Let it be clear of ranibizumab وعمل ليزر penretinal photocoagulation بعد تالت انجكشن فعلا. ده الاو سي تي بتاعه بعد 5 injections and laser penretinal photocoagulation. دكتور محسن هتنصح بايه دلوقتي؟
ممكن اشوف الفلوريسين تاني لو سمحت؟ يعني هو انا اول حاجه هفكر فيها بس ان انا اطلب الترا وايد فيلد اور وايد فيلد فلوريسين انجيوجرافي because I am searching for ischemic areas at the periphery. Maybe it's a factor for the resistance.
محسن هو عنده فعلا macular edema وعنده proliferative diabetic retinopathy. So there are a lot of ischemic zones in the periphery. وانت خدت القرار مظبوط هتديله انجكشنز وهتعمل له ليزر penretinal photocoagulation. جه بعد ما خد انتي VEGF انجكشنز 5 مرات عنده نفس المشكله في الماكلر اريا. البروليفريتيف دايابيتيك ريتينوباثي از كويسنت no more active. However, the edema is still there, affecting the foveal center. Vision did not improve.
First, I will be sure that the peripheral area are well lasered. Then I'm going to change the anti-VEGF.
Then you will go immediately and change the anti-VEGF after 5 injections. طيب وليد ايه رايك؟
مور انجكشن ممكن اغير الفيجاف واعمل PRP تايتنينج.
تغير الانتي فيجاف ولا تكمل عليه وتعمل PRP تايتنينج؟ تغير هتغير الانتي فيجاف؟ مش شور.
لا مش شور.
You might still do the same anti-VEGF injection and to add more laser. دكتور علاء اتفضل ايه رايك؟
I'm going to use laser in the posterior pole. I'm going to select focal laser for these many microaneurysms. It may help the previous injections to reduce the macular edema.
So you will think of doing laser. You will add laser more.
Yes, deferred laser.
Deferred laser. Oh, it's already deferred now. طيب ومش هتنصح بمور anti VEGF injections.
After 5 times ranibizumab, I don't think another anti-VEGF will be effective, in my opinion.
You will not think that other anti-VEGF will be effective. يعني مش هتغير.
I'm not going to change the anti.
You will not going to change, and you will not give further injections.
I may give. Actually, I'm doing OCT after each injection. and I have to see some change in the thickness. Okay?
So there is no change in the thickness.
If no
يبقى
change in the
anti-VEGF ده
thickness after
is
2
no longer
lines-
working, and you will not shift to another anti-VEGF.
Yes.
You will do laser treatment.
I'll do laser selecting for the microaneurysm.
طب أحمد سوكا.
If the OCT did not change over the 5 months,
Yes.
totally resistant case, I would change, of course, the anti-VEGF agent to see if other agents might work and add like 3 more.
Yeah.
If it still fails, I would consider after 9 injections of anti-VEGF without change in OCT and vision, steroid injections. But this is very rare. I didn't do it till now. They responded in 9 to 10 injections. They responded.
لكن you will not go for any laser treatment for the macula.
No laser
No
in
laser.
macula
No
for
laser.
diabetic macular edema in my hands.
طارق أحمد.
I would review my file whether the patient is compliance is good or not, because sometimes the patient get an injection and he skip some follow up.
compliant وجالك الخمس
The
أشهر.
laser in the central area seems to be good. I wouldn't add laser, but I should check the periphery whether I need to add laser at the periphery or not.
معلش أسألكم كده سؤال بالمناسبة كلام طارق. Anyone has an experience of adding more laser in cases of proliferative diabetic retinopathy and noticing that the macular edema improved after adding more laser? يعني لو عملنا هو proliferative diabetic retinopathy it looks quiet ما فيش activity. هل لو زودت laser treatment in the periphery this can improve the macular edema? In your experience أيوة يا محسن.
Alone could not improve the macular edema, but the response to anti-VEGF may be better. When I inject anti-VEGF after lasering the ischemic areas at the periphery, the response to anti-VEGF changes. It became better.
In your practice يعني أنت you don't believe that laser addition of laser will improve the macular edema, but it can increase the effectiveness of the anti-VEGF.
Yes.
حد بيشارك نفس الرأي؟ طارق اتفضل.
The ultra-wide field imaging ابتدى يفضحنا because we are not applying laser to the vast periphery, either because of the viewing system we are using to deliver the laser. There are ischemic area at the vast periphery. We cannot reach it with our viewing system, and sometimes these areas leak VEGF vigorously that induce macular edema, and we need to study this. I think the ultra-wide field, even with the injection, you inject, yes, but even in the vast periphery, we don't know what's going on there. The ultra-wide field may help us, but still the problem, how to deliver the laser to the vast periphery. I think peripheral retinal cryo could be an option in such cases.
هل additional laser treatment in these conditions can improve the macular edema in your practice?
I really don't believe in this. I really doubt this. I don't believe that it will not increase. As Ahmed Souka said, I think that we should start considering the use of corticosteroids. Something like
at this point you will start using corticosteroids?
This patient has received 5 anti-VEGF. He still has 1 more to be considered as a resistant case. Then I can shift to anti-VEGF. If failed again, then I would start considering corticosteroids.
So you give him a chance with 1 more anti-VEGF of the same type. If it didn't work, you go for steroids.
Yes.
تمام.
I would like to ask, did the vision drop after this?
The vision is almost the same. It was not a good vision anyhow. It was 660. أيوة اتفضل يا.
And I want to just mention the idea of the peripheral ischemia and lasering it. I can accept this idea in recurrent cases of DME, because after you control it with the injections, you get a recurrence. Maybe the periphery is producing again VEGF, but resistant cases, you injected 3 injections. No matter how ischemic the periphery was, the VEGF is downregulated. Adding laser will not make it less. The resistant cases, no change with PRP. Debatable in recurrent cases, I don't think it will work anymore.
واحنا برضو عارضين حالة متوقعين هو it's actually the laser has been done adequately to the far periphery you can see. يعني هو عمل ليزر فعلا كويس. اتفضل يا دكتور علاء عايز كومنت.
بالنسبة للليزر peripheral laser is going to make the condition worse. I think macular edema may increase, is not going to subside. Presence of so many hard exudates means that there is a leaky lesion, and these leaky lesions are mostly microaneurysms. So I think there is a role for focal laser here.
تمام. هو الدكتور علاء رايه ان احنا ممكن نعمل فوكال ليزر تريتمنت لغايه دلوقتي في القصه دي and this can improve the condition. الحقيقه ان العيان ده قبل ما اوصل بس انا اوضح بس نقطه ان احنا في اختلافات بيننا كده وبين بعض على ايه هو النون ريسبوندر. مين هو النون ريسبوندر بيشنت؟ تقدر يا دكتور عمرو تقول لي امتى بتقول العيان ده نون ريسبوندر؟
If this patient is receiving anti-VEGF هو هنا protocol I هو اللي عمل description. If after the first injection he did not get more than 10% improvement of the thickness with improvement of visual acuity, if after the second injection he did not get 20 up to 6 injections. If this patient did not improve by 10%, 20%, 30% per protocol I, then you should consider this patient a non-responder.
تمام. هو التعريف الاكثر شيوعا النون ريسبوندرز هم اللي بعد ما ياخدوا 3 to 6 injections 3 injections تحديدا over 3 months الثيكنس ما تقلش اكتر من 10% يبقى ده نون ريسبوندر والنظر ما يتحسنش اكتر من 5 لترز. ايوه يا احمد اتفضل.
انا كنت عاوز اللي حضرتك قلته ده انه النظر والثيكنس لو واحد فيهم اتحسن يبقى ريسبوندنج. يعني لو الاو سي تي هو بس هو شاف سطر زياده هيز ريسبوندنج.
احنا بنتكلم عن ده والفيجن والاو سي تي البارامترز بتاعتنا. والنون ريسبوندرز دول بصفه عامه عشان المجموعه تبقى حاضره قليل جدا النون ريسبوندرز اقل من 5%. طب في عندنا مشكله ثانيه ان في عيين بنسميهم سب اوبتيمال ريسبوندرز ما بيستجيبوش. الدكتور طارق حميده ايه امتى تقول عيان ده عنده سب اوبتيمال او inadequate response؟
If he improves less than 5%, but keep improving in each visit, this means that he have 5%, 5%, 5%, and he is still slowly gainer. They name them slowly gainer. The improvement in vision and the thickness is slowly, and they suppose that it could be genetically determined or something like that.
هو التعريفات الاكثر شيوعا يعني ان العيانين اللي هم عندهم سب اوبتيمال ريسبونس اللي هم بيحصل لهم less than 50% reduction in excess macular thickness after 3 to 4 monthly injection. خدوا 3-4 حقن تحسنوا بس ما تحسنوش اكتر من 50% اقل من 50 او نظرهم ما وصلش 20/40 بعد 3 to 6 injections provided that the cause of drop of vision is only macular edema. يعني ما عندوش macular ischemia ما عندوش epimacular membranes ما عندوش vitromacular traction او كده. العيان بتاعنا ده الحقيقه ده عيان من عيانيني انا يعني بعد ما خد ال5 حقنات الاولين ما تحسنش انا قررت اديله 3 more injections of the same kind. هو خد رانيبيزوماب 3 more injections. ده المنظر بتاعه الصوره الكومبوزيت فوتوجراف باين انه عامل ليزر كويس في البعين. بعد ما خد 3 حقن تانيين يعني كده وصل 8 حقن الاو سي تي بتاعه ده نفس المنظر. دكتور محسن ايه رايك؟ تنصحوا بيه يعني؟
انا بس عايز اتاكد من حضرتك العيان ده فيكك ولا سودو فيكك؟
العيان ده فيكك.
العيان ده فيكك. I will change to another anti-VEGF.
You will change بعد 8 حقن to another anti-VEGF. وليد.
اساسا I might change
to another anti-VEGF.
Recently sometimes I give up.
You give up. طيب هو الحقيقه انا عملت زي ما الدكتور محسن كده قال انا قلت هغير لانذر انتي فيجاف والمنظر ده كان بعد اول 5 حقن اولانيين وبعدين لما زودنا تاني 3 حقن تانيين الوضع ما اتغيرش ما فيش اي تحسن في الموضوع. طب اسمع راي الدكتور احمد سوكا انت اديت خد 8 حقن والعيان ما تصلحش.
حضرتك 8 حقن من نفس الانتي فيجاف.
نفس الانتي فيجاف.
هو نفس الانتي فيجاف definitely I will switch to the other anti VEGF.
To another anti VEGF but not steroid.
Yeah, I will shift. بس انا هاخدها step further and I usually change عند 6.
تمام.
فلتس consider ان انا حطيت 6 and 3 of another and still no response. يعني جربنا 2 anti VEGFs نقول Lucentis and Eylea. I explain options to the patient at this point and I prefer more injections. The options I explain are the steroid injections. I explain the laser and I say I don't prefer it and I don't like it. And I also mention I don't like steroids and the side effects. And I tell him there is an option to keep injecting and I prefer it.
طب دكتور طارق، لو العيان ده انت بتحقنه وعملت له 8 حقن وما تحسنش، هتقول له لو خدت السيم انتي فيجاف وكملت عليه ممكن تتحسن ولا مش ممكن؟
ممكن يتحسن.
ممكن يتحسن. لكن this would not be your first choice بقى في الوقت ده.
معلش هو السؤال why the fear for the change from anti-VEGF ل corticosteroid if the patient is cataractus for example, is not glaucoma prone patient, is not, why the fear for the shift from this molecule to the other molecule?
تمام.
Why shifting in the same molecule?
يعني رأيك دلوقتي أن at this point you will shift from anti-VEGF group to steroids.
If the patient is cataractus, if the patient is not prone to glaucoma, I would shift to corticosteroid.
تمام. عمرو ايه رايك؟
هو الميد ستادي في الاوزيردكس حضرتك قالت ان هو الانسيدنس اوف كاتاراكتس 21%. طيب if I lose his macula especially ان العيان ده كده بقى له 9 شهور suffering from macular edema, this means that the molar cells are degenerated, the photoreceptors are starting to get lost. I think we should relieve this edema as soon as we can, and I think that the use of Ozurdex here would be judicial.
So you agree on changing the molecule and you will go for steroids?
Yes.
Yes, at this one. طيب هو احنا الحقيقه بعد ما استخدمنا نوعين انتي فيجاف والعيان ما تصلحش we decided to go for cataract surgery, and we remove the cataract and we give the patient 3 more injections of another anti-VEGF. الحقيقه حولناه على افليبرسبت بعد دول وعمل cataract surgery وده after switch to anti-VEGF this was the case. تمام. محسن ده خد 8 حقن رانيبيزوماب و3 افليبرسبت وعمل كاتراكت سيرجري في الوقت ده والوضع هو الاتي. ايه رايك يا محسن؟
Now the patient is defined as non-responder pseudophakic. This is for me a pure indication for Ozurdex.
تمام. وليد.
Ozurdex.
دكتور علاء اتفضل.
Steroid injection.
Steroid, which type of steroid يا دكتور علاء؟
I'll first try triamcinolone.
Triamcinolone.
Yes.
أحمد سوكا, which type of steroid?
Steroids are justified at this point, not my preferred choice. If I can go for Ozurdex, it's better than triamcinolone. Yes. But many find it very costly, and we try triamcinolone. If the patient chooses steroids, I push him to more injections and not steroids. I push him for more injections.
So you can push this patient to more injections and not the steroids.
Yes, it's my
this is your first choice.
Yes, and Dr. Tariq asked why not change the molecule to steroids? Why the fear of changing? One, when I change to steroids, it's not a definitive treatment that will end things and we can finish this DME. Nearly all cases have a recurrence. Upon recurrence, I will shift to anti-VEGF again because the second time you inject steroids, the side effects for me are much higher and the IOP gets out of control after second and third steroid injection. So I never do this. It's not a definitive treatment. We will probably get a recurrence that will be maintained again on anti-VEGF. All studies said that steroids improve and come back with edema. So I'm not doing anything. I'm getting side effects.
دكتور أحمد سوكا رأيه إن هو هيكمل على أنتي فيجاف انجكشنز. دكتور طارق حميدة هرجع لك دكتور. دكتور.
معلش في أنا ليا 2 points. I'm older guy. I was using the steroids as the only treatment for treating diabetic macular edema before the era of anti-VEGF, and I was happy with the steroids at that
كويس.
time.
عايز تعليق واحد بس. حضرتك هتستخدم الستيرويدز. Which type of steroid هتستخدم؟
If the patient can afford, I would go for Ozurdex. If he cannot afford, I would go for triamcinolone.
طيب أنا عايز أسأل سؤال يا دكتور طارق. Regardless the cost, do you believe that triamcinolone is equally effective as Ozurdex?
Yes.
You do believe the same? Yes. دكتور عمرو إيه رأيك؟
I would only go for Ozurdex. I do not inject triamcinolone anymore. I don't think إن هو I think the incidence of glaucoma is very high. Ozurdex is a better option. And as Ahmed Souka mentioned, I will tell the patient that you are going to have a 2-month, maximum 3 months vacation. Then we are going to reinstitute injection of anti-VEGF again.
طيب أنا هرجع للدكتور علاء فاضل. At this moment, would you believe that additional focal laser treatment to this patient can help resolution? يعني ممكن نرجع تقول العيان ده هناخد focal laser دلوقتي بعد ما عمل 11 انجكشن وعمل كاتراكت سيرجري.
معلش هو انا عندي سؤال يعني هو ليه عمل كاتراكت سيرجري؟ باين من الصور هو 52 years and
هو عمل كاتراكت سيرجري لان هو كان كاتراكتس. هو انا سالت الاول هل عنده كاتراكت؟ كان عنده كاتراكت. كان عنده كاتراكت.
During cataract surgery why didn't you inject steroids or something during the operation؟
ده حل من الحلول. لو كنت هتختار الستيرويدز ممكن تحقن معاه زي ما انت بتقول ممكن تحقن.
طيب this patient lost a lot of money, lost confidence and trust in my treatment. He's just sticking to you because you are Dr. Ahmed Magdi. And now I'm going to tell him Ozurdex and he's going to pay 12,000, 14,000. So I think one shot of triamcinolone as a test for his response for steroids is a better option.
So at this moment you will choose steroids?
Now I can prefer triamcinolone over laser because he is pseudophakic.
تمام. At this moment you can do triamcinolone injections and following triamcinolone you can add more laser or no more laser?
No more laser. If what about the response? Look at the response and see.
Usually these patients respond to steroids. هيقل الماكيولار thickness شوية عندهم.
If the response is good for triamcinolone, I'm going to propose for him Ozurdex.
You will propose Ozurdex. عمرو انت خد العيان ده 11 انجكشن انتي فيجاف وانت قلت هتدي له Ozurdex at this moment. Would you add laser after subsidence of the macular edema at this point بعد ما الإديمة تروح وانت اديت Ozurdex؟ ممكن تعمل ليزر تريتمنت in your practice؟
لا
ما تعملش.
لا
ما تعملش. طيب دكتور أحمد عبد الهادي, is it time to think of doing surgery at this moment?
أنا بشكر حضرتك على الحالة دي. الحقيقة حالة very representative. أنا هاخد من كلام الدكتور علاء كلمة مهمة. After 6 or 5, in my opinion, 5 or 6 injections of the same anti-VEGF is enough. I would shift to another anti-VEGF, probably aflibercept, for 2 injections. And if the patient didn't respond, I will shift to steroids for only 1 injection. هاخد من كلمة بالدكتور علاء. البيشنت احنا بنعالج patients according to our expert opinion, according to the studies. According to the studies, a refractory macular edema patient ما فيش اي ستادي قالت على ريفراكتوري ماكل اديما. كل ده اكسبرت اوبينيون، كلهم حاجات بتشتغل في ايدنا، لكن ما فيش اكتر من 30-40% سكسس ريت. ما فيش السكسس ريت بتاع الفيرجن كيسز. اتحدى ان حد من الموجودين يقدر يقول تو هيز بيشنتس بعد 11 انجكشن اوف انتي فيجاف و2 انجكشن اوف ترايمسيلون انا هعمل لك اوزوردكس، هعمل لك ترايمسيلون، هكونتينيو انجكشن and I'm sure 80% or 90% the next treatment will work. اتحدى ان حد فيهم، انا شخصيا مش هقولها، لكن this patient زي ما الدكتور احمد سوكا قال هبتدي اقول له بعد 5 injections of the same anti-VEGF shift to another anti-VEGF عشان tachyphylaxis usually aflibercept trial of 1 triamcinolone. انا خلاص كل حاجه استخدمتها، البيشنت ما بيتحسنش، هبتدي اتكلم معاه في الاوبشنز اللي اتكلم معايا الدكتور احمد سوكا، اقول له كل ده بينفع، لان الريفراكتوري دايابيتك ماكل اديما ما لهاش كونسنسس بيننا، ما لهاش حاجه متفق عليها، ما فيش ستادي بتقول في تريتمنت اعلى من الثاني ب 30-40%. هقول الاوبشنز دي ان كونتينيو ترايمسيلون انجكت مور، لكن اي ويل توك اباوت فيتريكتومي. وفي رايي السيرجري دي وانا عملتها في اكتر من 60 عين انا اقدر اضمنها للعيان بنسبه 80-90%. هتعمل السيرجري دي هتخلص الموضوع، وخصوصا لو العيان ده كاتاراكتس هعمل له فيكو فيتريكتومي. و حضرتك لو رجعت الصور، معلش حضرتك ارجع بالصور ثانيه بس، حضرتك ارجع بالصور ثواني. الاو سي تي حضرتك لاحظت ان الاو سي تي بتاع البيشنت ده هي ديفلوبد فيتروماكل انترفيس ابنورماليتي في الابر ليفت كوادرنت. طبعا دي this is not an anthroposterior traction، دي tangential traction، وفي رايي ما تعوقش التريتمنت اوف انتي فيجاف، لكن لازم احطها في دماغي. لو انا بحقن البيشنت انتي فيجاف وما بيستجيبش وفي فيتروماكل انترفيس ابنورماليتي بتزيد مع الانتي فيجاف انجكشن، وبروبلي الليزر يكون زودها، دي ممكن تستفيد من ريليف اوف ذس فيتروماكل انترفيز ابنورماليتي بالفيتراكتومي. انا رايي ان البيشنت ده معاد الفيتراكتومي فيه. لو استنينا اكتر من كده البيشنت هيستجيب سنترال ماكلر ثيكنس، اضمن لك ده بالسب ريتنال انجكشن، لكن مش هيستجيب فيجن عشان الابيسويد والاكسترنال ليمتنج ممبرين. فلازم نوفر ذس تريتمنت فيري ايرلي، وانا عملت بقول لحضرتك اكتر من 60 عين انا ام فاسينيتد وذ ذا ريزلتس.
طيب انا بس هرجع لحته السيرجري تاني، بس هنمشي ثانيه يا احمد وهرجع لك في حته السيرجري تاني. اوكي. هو العيان ده احنا مختلفين، الماجوريتي بيتكلموا عن ان هم يستخدموا ستيرويدز، والدكتور علاء فاضل والدكتور طارق حميده قال ممكن يستخدم تراي امسيليون الاول، ومحدش جاب سيره السيرجري. انا سالت احمد يقولها لان عارف ان هو اشتغل حالات كتير كده من السيرجري. هل الاديشن اوف ستيرويدز وتحديدا اوزردكس للانتي في جيف انجكشنز بيحسن الامور ولا ما بيحسنهاش؟ This was the object of the protocol U study اللي هي قالت هل الستيرويدز لو حطيناها مع الانتي في جيف هتحسن الامور ولا لا؟ فقالوا ان العيانين اللي لو واخدين 3 انتي في جيف انجكشنز ونظرهم ما تصلحش والاديمه ما راحتش، اعمل لهم ايه؟ هديهم كمان 3 انتي في جيف انجكشنز اوف ذا سيم تايب. بعد 6 انجكشنز ما تصلحوش هقسمهم لمجموعتين 2، مجموعه هتمشي على انتي في جيف بس، ومجموعه هتمشي على انتي في جيف وتاخد اوزردكس معاه. اوزردكس ات بيز لاين، اوزردكس كل 3 شهور معاه. والريزلت بتاع الاستادي قال ان الثيكنس اوف ذا ريتنا از بيتر ان ذا كومباينيشن جروب، السمك الريتنا بيتحسن لكن الفيجن does not improve في الجروب اللي بتاخد اوزردكس وانتي في جيف عن الجروب اللي بتاخد انتي في جيف فور 6 انجكشنز. والكونكلوجن هقراه لكم كده وعايز اعرف رايكم انتم موافقين عليه ولا لا. الكونكلوجن بتاع البروتوكول يو: further studies on this topic are not indicated as many eyes continue to improve in the anti-VEGF only group after 6 months. يعني رايهم ان بلاش بقى ندرس الموضوع ده العيين اللي ماشيين على انتي في جيف انجكشنز مره كل شهر ممكن يتحسنوا بعد 6 شهور كده اكتر، والموضوع ده ما يستحقش دراسه ثانيه. اول سؤال عايز اساله لكم، لحظه واحده مثلا، انتم موافقين على الكونكلوجن ده بخبراتكم في استخدام الاستيرويدز والانتي في جيف؟ موافقين ان العيانين دول امر ما يستحقش اهتمام ان احنا نحط اوزيردكس مع انتي في جيف وبتاع؟ طيب محسن اتفضل.
الاجابه لا، انا مش موافق.
مش موافق. In your clinical experience you feel that steroids add to the effect of anti-VEGF regarding the thickness and vision?
Yes. But long-acting dexamethasone implant, not triamcinolone.
احنا we are talking about dexamethasone، ما هو البروتوكول يو على الدexamethasone. تمام.
وليد السب جروب السودوفاككس في الريزلتس مش مذكوره هنا. هم اكسكلودنج السودوفاكك جروب ان هم get better or get benefit from dexamethasone implant, especially pseudophakic group.
وليد
في الريزلتس
بخبراتك هل الاستيرويدز بتدي افكت زي الانتي في جيف احسن اسرع؟ هل ايه رايك؟
ممكن تسرع شويه.
ممكن تسرع شويه. دكتور علاء.
بص حضرتك، انا جربت الانتي في جيف مع very purple steroids with no effect, anti-VEGF with micropulse laser, no effect. Intravitreal steroids will give effect, and intravitreal steroids and laser are more effective. These cases need mixed therapy, not monodrug therapy.
Yeah, so you feel that triamcinolone injections مع الليزر في resistant cases أحسن من الأنتي في جيف.
These are my weapons.
طيب، دكتور أحمد سوكا.
طبعا I agree totally with this conclusion. This was my practice, and this is why I said I tell the patient I want you to continue anti-VEGF and not the other options that I will explain at this point because it's valid. But the 2 other options, let's say steroids and surgery, in all studies we've seen, all this like 5 years, the last 5 years, patients do not gain vision. However, with continued anti-VEGF injections, studies showed that if you continue for 3 years, 50% of patients improve in vision. These are post-hoc analyses of protocol T, the most important of them, and these are the only studies that showed patients with gain of vision in this regimen. All other regimens, steroids or surgery, no visual gains.
احمد انت in your practice كام في المية من العيانين دول الريزيستنت لما تكمل monthly injections of anti-VEGF بيتصلحوا؟
30 to 40% after 2 years.
دكتور طارق.
No, I combine surgery. I'm not insisting on doing anti-VEGF for that. I go for.
هو الاستاذ مطلع الامبروفمنت بعد سنه ممكن تبقى 28% من الحالات. عمرو ايه رايك؟ You agree on this conclusion?
I will go for injection and steroids. I don't actually advise surgery.
Injections and steroids.
Yes.
You will keep on injections.
Yes.
And in your practice, do you feel those patients with resistant edema, if you give them steroids, do they feel better? Patients themselves?
Yes. Yes. They actually feel some form of not visual acting improvement, but they feel better, and actually the response to anti-VEGF injection later is much better when they have received corticosteroids.
تمام. أنا قبل بس ما أفكركم جميعا إن الباثوجينيسيس of diabetic macular edema is not only dependent on VEGF. في group of patients dependent on steroids. Steroid inflammation dependent. I mean, so steroids has a role in the management of these cases. طيب ده عيان جاء كده with the glistening sheen at the macular area as if he has an epimacular membrane وعنده probably a non-ischemic non-proliferative diabetic retinopathy, and this is the OCT of the patient showing tangential traction on the retina. دكتور محسن in your practice العيان ده وهو عنده tangential traction تنصحه ياخد anti-VEGF injections, steroids, surgery او to counsel him ازاي على البروجنوزيس بتاعه؟
I will tell him that I will start with anti-VEGF injection with less opportunity for success that because of the presence of the tangential traction. If there is no response after 3 to 5 injection, I will go for surgery.
For surgery. احنا بنشوف كتير العيانين اللي عندهم epimacular membranes كده فوق الماكلر اريا والrecommendations of the studies and they have to keep on anti-VEGF injections. انا احب اعرف ارائكم الشخصيه مش الستاديز. دكتور محسن قال هديله 3-4 انجكشنز لو ما تحسنش هقول انا هدخل اعمل له عمليه. دكتور وليد.
انا حاسس ان الانجكشن مش هتفيد و I would follow up and compare with vision. لو الفولو اب الفيجن ستيبل والاس تي ستيبل هفولو اب لو في
لا يعني مش هتدي له انتي فيجاف انجكشن مش هتدي يعني. دكتور علاء.
Is he phakic or pseudophakic؟
أنا مش فاكر قوي، مش فاكر العين ده تحديدا عشان أكون صادق.
If he's pseudophakic, I'll give him intravitreal steroids.
Steroids not anti-VEGF.
Not anti-VEGF.
أحمد سوكا.
Regular DME treatment, free.
Anti-VEGF injections and follow up. طيب أنا هقف قبل ما أوصل للدكتور طارق كده هقول لأحمد سوكا العيان ده خد 3 anti-VEGF injections and this is the picture بتاعته. دكتور طارق هو حصل له فعلا reduction of central retinal thickness الابيماكيولار membrane is still present. In your experience العيان ده بعد شهر ونص شهرين من آخر انجكشن دي هترجع له الماكيولار إديمة تاني ولا هيتحسن وممكن يستفيد أكتر منه؟
لا أنا أعتقد إنه هترجع له الإديمة تاني بس في تشينج حصلت في الديسربشن في الأوتر ريتنا مع الانجكشن.
تمام.
The outer retina is disrupted in this photo, so the vision. I suspect that, in spite of decrease of thickness, I think he lost vision.
His vision is the same ما تصلحتش بس أنا بسأل نقطة محددة. أنت في خبراتك إن العيان ده هيتنيه anti VEGF dependent يعني تدي له حقن ويرجع تاني يديمه وتدي له تاني anti VEGF injections؟
Yes.
تمام. هيتنيه كده and you should tell the patient this from the start.
Yes.
عمرو.
And I think this patient is going to have recurrence, especially that he is still having central involving edema.
Yes, he still has.
Still having. So, I think he is anti-VEGF dependent.
So you will tell the patient you will be dependent on anti-VEGF وهتدي له anti-VEGF باستمرار.
Yes.
And despite إنه نظره ما تحسنش هو الثيكنس قل ونظره زي ما هو ما تحسنش.
He can improve later on.
He can improve later on. طيب. الحقيقة دي مشكلة من المشاكل يعني اللي أنا يعني مش انا عارضها عشان اخد قرار الجروب فيها، بس دي مشكله الحقيقه هلخص لكم. ودي اخر حاله ممكن حاله في البرزنتيشنز وممكن تجاوب على السؤال ده. 48 years old male type 2 diabetes complaining of gradual diminution of vision dating 7 years. بقاله 7 سنين العيان ده نظره بيقل. خد multiple intravitreal injections of different types including steroids. خد 6 injections in the last 6 months. راح لحد من الدكاتره كويسين وقالوا لا انا هدي لك افلي بيرسبت مره كل شهر 6 مرات متواصله في اخر شهور. فيجوال اكيوتي بتاعته كانت 560. لو بصينا للصوره دي كده في بليستر لايك ليجن هين ات ذا ماكلر اريا، في يلوش ليجن كده which looks like fibrous tissue. And this is the composite photograph of the periphery of the retina, incomplete laser treatment at this part. And this is the fluorescein angiogram of the patient. دكتور طارق لما تقرا لنا الفلوروسين ده ايه رايك؟ تقول فيه ايه؟ هو الحقيقه ده فلوروسين معمول اوتسايد يعني مش عندي.
He has some sort of intensive laser treatment, confluent laser treatment on the nasal side, whereas the temporal side is devoid of laser treatment.
So this is incomplete laser retinal photocoagulation?
Yes, inadequate distribution of the laser treatment, and I think this inadequate distribution of the laser treatment is worse than not doing the laser treatment itself, because these areas looks very ischemic in delivering anti-VEGF, and in color photo, threads, vessels, and severe ischemia, you can manifest it on the temporal side of this patient. Again, this lesion, which is present at the central at the juxtafoveal area, it does not leak in the late phase. It shows some sort of early hyperfluorescence, and later on it does not leak. This indicates that this is some sort of deposit or something like that. Yes.
You know, you're talking about this peripheral temporal.
No. I'm not talking about the subfoveal, the subfoveal area. Yes. So I need to explore the nature of this one with the OCT.
There is pooling of the dye in this area, and this is the OCT of the patient. You can notice the structural OCT here showing this very large cyst. This is cystoid macular edema. There is tangential traction here, and this is the fluorescein, and this is the structural OCT of the patient. He has such a very large cyst. عيان خد حقن لا حصر لها آخر 6 شهور، خد الحقن دي regularly every month. And we have this problem, and we have this tangential traction. Would you advise this patient to go for more injections for steroids, or this is the time for surgery?
I think that this is a time of surgery, but I wouldn't promise patient vision in such case because of the large cysts or the incidence that these cysts may rupture during surgery from me or something like that. I don't know the prognosis.
What surgery? Vitrectomy, epimacular membrane removal?
Yes.
ILM removal?
ILM. Vitrectomy with ILM.
Amr, do you agree the same?
Yes, I would go just and mention to the patient that I'm doing this to prevent further deterioration. As I mentioned here, there was a study, especially this is very significant of that when you do vitrectomy ILM peel in this case, this cyst will collapse with thickening of whatever is under the cyst, and they call it the after cyst with no improvement in visual acuity.
So you'll just expect this cyst to collapse, the edema to resolve, and vision will not improve.
Yes.
Vision will not improve.
Yes.
So وليد انت رساله الدكتوراه بتاعتك كان الفيتريكتومي والاي ام بيلينج في الدايابيتكس، ايه رايك؟
بيبقى في anatomical improvement بس not essentially functional improvement.
في anatomical وما فيش functional improvement. طب الاناتوميكال improvement بتبان بعد قد ايه في الحالات دي يعني؟
3 months.
3 months. So you don't expect rapid improvement of the edema fluid. محسن ده this is a patient for surgery?
For me, I don't think if I'm searching for a beautiful OCT picture, I will go for surgery. But I don't think he will benefit from it.
You will not think that this patient will benefit. Anyone would think that this patient can benefit from surgery? ولو مش هيعمل surgery هتقول له كمل على الانجكشنز او ولا بطل؟
هو this was my question. if there is no place for surgery, what is a place for what?
What to do? أحمد اتفضل منسوك.
The patient already knows that he's not improving despite a lot of injections. He knows. If he felt an improvement in scotomas, in whatever clarity after the injections,
the patient is not feeling any improvement.
I would advise doing nothing, lasering the temporal retina for MVs. Yeah, the laser for the PDR and the tractions and the new vessel bleeding, not for the diabetic macular edema. And I would tell him that he will be advised for surgery because there is an periretinal membrane and I expect no improvement in vision and I will not do the surgery.
You will not do the surgery, you don't feel that surgery will let him benefit. أيوة وليد اتفضل.
بس نقطة صغيرة إن الحالات اللي هم أخدوا multiple repeated وإن هم not responding أول حالات اللي فيهم periretinal membrane وأنا يعني إحساسي إنها مش هيتحسن بمالتيبل انجكشن لما بقول لهم على ميديكال تريتمنت بيبقوا much relieved وساتيسفايد وستابل.
ما تعملش حاجه وده عمرو. do you expect this patient to benefit visually؟ انت قلت لي لا هتحسن anatomically. طب لو هتحسن anatomically هتحسن بعد قد ايه يعني؟
This patient anatomically,
yes.
I think in a short period of time, I think in less than starting from 3 weeks, he can have anatomical
3 weeks. طيب انا حقيقه لازم اقول يعني ان احمد عبد الهادي بقى له 2 بيقول لي ان السيرجري دي مفيده وانها بتجيب نتائج كويسه. احنا عندنا اكسبيرينس كده قديمه من زمان ان احنا عملنا سبريتنال سيرجري فور ريموفال اوف سبريتنال نيو فاسكولار ميمبرينز وكان في نفس الوقت ناس بتعمل سبريتنال سيرجري تو ريموف هارد اكسوديتس من الماكله والريزلتس بتاعت السيرجريز ما كانش النظر فيها بيتصلح من العيانين. الحقيقه انا قررت ان انا اعمل السيرجري دي في العيان ده. هو الفيديو مش شغال نفسي اتس اوكي. التراديشنال اندكشن اوف بي في دي انا جايبها يعني عشان بس يعني نبين ان there might be an option which can be used in the proper time and can help patients. ودي المسج اللي كان احمد عبد الهادي بيقولها في البرزنتيشن بتاعته. ده انا عايز اجريه بس بعد الاي ال ام مش قادر اجريه اسرع من كده. بس هو ده العيان عمل فيتريكتومي تراديشنال اي ال ام بيلينج اللي هي كانت رساله وليد واللي انا كنت الحقيقه مشرف عليها. وعارف زي ما هو قال وليد العيانين دول ما بيتصلحش نظرهم كتير وعندهم a lot of field defects بعد السيرجري وكده. لكن this is something different يعني بعد ما شلنا الاي ال ام هو مش هياخد دقيقه كمان ثانيه حققنا له سبريتنال بي اس اس. It's a simple technique of subretinal BSS injection. You will notice this cyst وصلت للفوفيال center. I didn't inject more than one injection بس. وقلت الفلويد اير اكسشينج هيسبريد الفلويد في السبريتنال سبيس. ده تكنيك معروف وما فيهوش مشكله. النقطه المهمه ان هو بعد السيرجري مباشره ده كان 6 ايام بعد العمليه في الابر تمبرال ريجن. لو انتم شايفين الصوره بتاعت اللي موجوده هنا مغطيه على الاير بابل موجوده لسه موجوده جوه العين. دي الصورة اللي قبل السيرجري. You can notice the presence of this cystic lesion الكبير اللي موجود الفلويد الكتير اللي موجود ده هنا. This cyst is not apparent on the colored photograph. عايزين نشوف طبعا during the surgery laser permeable photocoagulation has been completed. ده صورة العيان الاو سي تي بتاع العيان قبل السيرجري وده 6 ايام بعد السيرجري. هل حد فيكم شاف تحسن اناتوميكال 5 6 ايام بعد السيرجري كده في اي سيرجري اتعملت للدايابيتك ماكلر ايديما؟ شفتوا التحسن ده؟ انا الحقيقه اول مره اشوفه يعني. ده تحسن جامد جدا في عيان خد الفرصه للسيرجري دي ليت. خدها ليت اتاخر على ما عمل. ده بقاله سنين بيعمل كده. العيان ده ده اليوم اللي انا كشفت فيه عليه بعد العمليه. قال انا حاسس ان انا نظري زي ما هو ما اتحسنش. انا تيستد نظره فعلا لان الاير بابل كانت موجوده فوق، نظره 65 زي ما هو، بس ده بعد 6 ايام من العمليه. بالمناسبه ما فيش استيرويد استخدم في العمليه دي خالص، حتى في الاندكشن اوف بي في دي اي دونت يوز ات ريجولارلي، ما بعملوش فده this is the mere effect of the surgery with subretinal BSS. احنا عملنا حالات كتير لدايابيتكس ما بيتصلحوش كده بسرعه، وحتى لما بيتصلحوا ما بيبقاش كومبليت ريسبونس للتصليح كومبليت. انا بشكركم جدا على كل ارائكم القيمه، وبشكر احمد عبد الهادي على ان هو لفت نظرنا ان في حاجه ممكن تتعمل العيانين دي تفيدهم لو اتعملت in the proper time ان شاء الله. وبشكر كل السبيكرز تاني على كل البرزنتيشنز الجميله بتاعتهم. شكرا جزيلا لكم.
شكرا جزيلا.